lunch.
Yes, sir.
It's 2:30.
Me?
And we can go live.
Okay. A very good afternoon to one and all of you for our ARC webinar on Challenging Debate Series. And we look forward to a great 2.5-hour session. I'm sure it's going to be sizzling with controversies, rebuttals, and gainful learning. We have a great expert panel who would steer us in the course of this webinar. We have with us our President AIOS, Dr. Mahipal Sachdev, who has weathered AIOS and steered it most appropriately with great commitment in this unprecedented times. We have with us our Honorary Secretary AIOS, Dr. Amrita Sharma, who has been a leader amongst leaders in her tenure, which has been even more challenged in these difficult days. We have with us our past President, Dr. Ramurthy, with a great track record of being a teacher amongst teachers. We should be having Dr. Partha Bishwas joining us soon, a dynamic chairman scientific committee, a debater par excellence himself, besides his innumerable great attributes, who would also add to overseeing that nothing is left unturned in this debate session. We are truly lucky to have with us, truly lucky, Dr. K.K. Mehta, who's the doyen of ophthalmology, held in highest esteem, be it in his skill sets, his innovations, or his prolific stature, to truly escalate the standards of Indian ophthalmology. We have with us Dr. Gaurav Luthra, a very popular ophthalmologist, Chairman and MD of Drishti Eye Center, Drishti Eye Hospital at Dehradun, Chairman IRSI, to add strength to this afternoon's event. I have co-moderating with me Dr. Harshul Tak, another young dynamic leader who evolved the concept of life beyond ophthalmology group, which seems to have given space for great learning, great talents to evolve, who's also the chairman scientific committee of Rajasthan Ophthalmic Society and member ARC Central. Moving on to the great debate series, we shall go on to our first team. And our first speaker is the young Dr. Atishwar Das, who's a consultant ophthalmologist at Medicare Eye Clinic and Apollo Specialty Hospitals, Chennai. He's going to be debating on a very interesting topic. Indian premium IOLs are good enough, is what he has to say. And he is going to be challenged by Dr. K.K. Mehta that imported premium IOLs only justify the cost. On to you, Dr. Atishwar.
Thank you, ma'am. Is my screen visible?
Yeah, you're sharing your screen.
Is it visible?
Yes.
Thank you. At the outset, I'd like to thank Chairman ARC, Dr. Chitra ma'am, for giving me this opportunity to be part of this illustrious panel and this webinar today. I'd be talking today on Indian premium IOLs, and they are good enough for our patients. On this auspicious day of Mahavir Jayanti, I'd like to seek his blessings to overcome this dark period. So, why do I prefer Indian premium IOLs? So, I've been given 5 minutes to talk, and I'm going to talk on 5 pertinent points. So, the first one, keeping with the sentiments, we need to be vocal for a local, source locally, and promote our locally grown companies. The second point I'll be touching on is going to be about economics and the financial concerns when we are using the Indian versus the imported intraocular lenses. And of course, our Indian technology is at par with global standards. Of late, I'll be talking about that as well. Find the patient satisfaction and outcomes also matter a lot. And finally, due to the uncertain times we are facing right now, COVID pandemic, getting these imported lenses into our library or the expand series power, the low and the high outdoor power will be very difficult going ahead. Coming first to the economics, I'd just like to cite an example of a premium intraocular lens in a mid-level practice or a startup practice. An Indian multifocal hydrophobic lens would cost around 10,000, whereas an imported multifocal hydrophobic lens is starts at 28,000. There itself, you save around 18,000 per IOL. And if you put a very optimistic average of just 4 multifocal lenses in the month for a mid-level or a startup practice, you save directly 72,000 a month. And the yearly savings could definitely set you back by 8 lakhs. And you can definitely use this to buy an YAG laser or a B-scan. And more importantly, now with the insurance setting in and not paying for the premium lenses, most of these premium intraocular lens surgeries are out-of-pocket expenditure for most of our patients. And it is also uncertain whether insurance are going to pay up for these lenses. Coming to the second point, which is the technology, which is commercially available in the different types of trifocal lenses. I'll be quoting a trifocal lenses as an example, as a premium lens here. We have different types of trifocal, the Physiol, which is an apodized trifocal, then the non-apodized AT, Lara, and the Panoptics. These are all the well-known brands, globally renowned brands. And we have a very own Indian trifocal, which has been developed with a proprietary technology that there's an increasing angulation and decreasing height from the center to the periphery. It's a patented design and it's been incorporated in this lens. I have no financial interest, but I have implanted this trifocal from the Indian company, and it's given really good and remarkable results. And the lenses, again, the technology used to manufacture them, we use the state-of-the-art cast molded lenses with less imperfections. Cast molded lenses are those lenses which are made in a cast. So compared to a lathe cut lenses, the imperfections are less. So when you go for a premium lens like a multifocal or a trifocal, the amount of distortions or amount of photopsia is definitely going to be less with the cast molded lenses. So Indian lenses also now come with this cast mounting technology. And this is just an example of a trifocal, Indian trifocal, showing the MTF value or the amount of energy distribution by the lenses at different pupil size. The blue light is the 5 mm, the blue line is the 5 mm pupil size, the red is the green, and you can see there's almost equivalent light distribution in the between the 5 mm and the 3 mm pupils. So it is not very much pupil dependent as well. We did a small patient satisfaction study and the visual outcome in our center where we took our own data. It was a retrospective study where we had 50 eyes, which we had taken of 25 patients, and Physiol, AT Lisa were implanted, and Symphony for the imported lenses, vis-a-vis the Indian lens, the triphobic was implanted. So these are the lenses we compared, the post-operative outcome. They are all done by a single surgeon in a single hospital setting. So the same methodology was followed, same pre-operative workup and diagnosis. These are the basic differences from these lenses that I'll be happy to share with you later. Due to want of time, I can only say that all the 3 trifocal lenses are equivalent to the light distribution between far, intermediate, and near. The results were also very encouraging when it comes to the Indian lenses. I compared the visual acuity first week, 1 month, 3 months, 6 months, and 12 months. So you see the distance visual acuity, which was tested at the regular LCD vision chart at 3 meters, was 612. This is a logma visual acuity where the 0.1 is around 6 by 6 parts, 0.2 is 6 by 9. So most of the lens, 90% of the lens patients in having triphobic also had 6.9 or 6.12. First week, they improved to 6 by 6 at the end of 3 months and 6 months. The intermediate vision chart, which we used, was the Colin-Bronder modified chart, which had both high contrast and the low contrast, and we used it for testing at 63 centimeters and 100 centimeters. Here we see we tested at 63 and 40 centimeters for near, and you can see triphobic does measure up to the other trifocals available globally renowned brands like Physiol as well as AT Lisa Tri. Initially, the first 1 or 2 months, we had some amount of adaptation, neural adaptation, which had to take place for the patients to start reading intermediate vision. When it comes to intermediate vision at 100 centimeters, here again you can see the Physiol, the trifocal, which is the apodized diffractive trifocal, did very well for the near visual acuity, equivalent to AT Lisa Tri of Zeiss, and finally followed by triphobic. Symphony, when we did the micro monovision, they did better when implanted bilaterally. So to conclude, the trifocal lenses, the Indian lenses, triphobic, does provide good near and intermediate vision vis-a-vis the imported ones. The photic phenomenon was almost equivalent. It is again very subjective. Patients never came to us complaining about these photic phenomena unless we persisted and inquired with them showing these images. The near and intermediate vision was equivalent with triphobic and physiol. And just show a small video of the different lenses which are being implanted. All of them except physiol comfortably passed through a 2.2 millimeter incision. Physiol had an optic size of 6.25. It was a quadrupod, so we had to enlarge the incision to 2.6 or 2.8 mm to implant it. And the Indian trifocal made of hydrophobic, glistening-free acrylic material was centered in the bag. This is the AT-LISA, the top left-hand corner is the AC-LISA plate haptic of Zeiss, which is again a hydrophilic with hydrophobic surface. We had encountered two different patients, two eyes of having a PCO at the end of 1 year of follow-up in the hydrophilic lens segment. So at the end of, we did a slit lamp photography to look for the visual axis and the clarity at the end of 6 months and 1 year. And these hydrophobic lenses, the Indian hydrophobic lenses, did perform remarkably well at the end of 1 year without any PCO in our study group. There are more videos, but due to want of time, I will not be able to share them here. You can definitely go see them in our website, the YouTube channel. So finally, coming to the last slide, I kept wondering, why do our Indian patients or even Indian surgeons prefer imported lenses? I came across this very interesting article on Money Control about the aspirational values. Why Indians long for imported or foreign technology? It's probably due to the Indian mindset, which is colonialism condition and makes us feel anything imported is of better quality. We are proud of Kamala Harris, but we want foreign sounding names like AT-LISA and Lara in our intraocular lenses, and we don't want Indian names like Padmini or Kamala in our lenses. So I stand vindicated that my Indian intraocular lenses are as good as imported lenses. Thank you for your kind attention.
Thank you very much, Dr. Atishwar. Mr. Sunil, I would want you to keep a watch on the time. And after the first team is over, we would like to watch Entode's video. You heard me, Mr. Sunil? It's not there. Mr. Sunil? Okay, I'm very sorry for the interruption. We shall go on to our next debater, Dr. K.K. Mehta on the first team. Dr. Atishwar, you're really good. Gave us a great insight about where we stand and great information.
Thank you very much.
Dr. K.K., can you share?
Sure. Share screen. Can you see my screen?
Listen, Papa. Can I see,
Yes,
listen
can.
because this is a lag.
Can you see my screen?
Yes.
You can see my screen?
Yes, we can see.
Good. Let me start off. Dr. Atishwar gave a wonderful address. And let me try and justify why I still do what I would say is about 30% of all my lenses as premium lenses in the imported category, while 60% of my lenses are still lying in the Indian category. But there's a reason why it occurs, and let me explain. Are all men created equal? The belief that everyone is created equal, that we are fundamentally the same chance to success, is fundamentally flawed. Truth is, we are not created equal. Every person has a unique set of strengths. And in a similar manner, not all IOLs are created equal. They may look the same. They may smell the same, but they're not the same. Wherein lies the difference between, let us say, a Ciaz car and a BMW? They look almost identical, as you can see here, but there's a world of difference under the bonnet. What are we paying for when we pay the extra higher premium price? We essentially pay for the material, the proprietary research, the advances in the quality of the optics, the stability of the vision, and the long-term quality. I'd like you to come out with a basic concept. It's the painter, not the canvas of paint that matters. It's not the material or the pattern of the lens that matters. Thus, the design matters, not just the appearance and the material. Advantages of imported lenses is essentially a clearer vision, eliminate need for corrective, less distortion, less glare and flare, and a newer application of design. Designs are the same. Almost everyone has copied the same, but still some of the original designs which are now evolved over a period of time are significantly better. The Lisa, for example, which is the lens I tend to use to a large extent, gives me great independence of pupil size, good light intensity, and it gives me the advantages of an enhanced contrast vision, less dazzling, and the ability to adjust to binocular vision very rapidly. Something which was shown very effectively in Atishwar's slides, that the getting it working simultaneously was great. Other thing about these lenses is what I call as a panoramic view. The periphery of the lens has a change in design. And this, especially in two of the lenses, that is in 80 Lisa and the Panoptics, gives you a far better peripheral, clearer vision than it does with the Indian lenses. Halos and glare are significantly less. Most important of all, we no longer have to bother telling the patient that he will have difficulty seeing. And the better control is, most important, is of what we call as chromatic aberration. When light passes through a lens, it breaks into different colors. And with a good lens system, you can focus the lens better. The material of the lens contributes to the chromatic aberration, and both the Symphony, the Panoptics, and the Zeiss are built on proprietary hydrophobic platforms, which make a difference. Again, the advantages of sterility. Preloaded lenses make loading much easier, reproducible. You can position it, especially in toric cases where you want it to go. And most important of all is the stability of a toric lens. It doesn't turn. Especially the lens which I tend to use to a large extent, the Zeiss, just sticks into place. Turning is comparatively rare. So, and lack of rotation will make a toric lens much more stable. You have the advantages of utilizing the swept source system and of utilizing a proprietary premium IOL placement. And the big advantage of utilizing these two is the combination of the software. Though all IOLs have a software to effectively contribute toric placement, premium IOLs have their own designed software which ensures an accuracy of plus minus quarter. Though my favorite peep with all lenses is, why do you make them in half diopter steps? You should make them in quarter. So thus, reducing it down, the advantages of the premium are sharper and clearer vision, much less distortion, less glare and flare. And as I like to tell the patients, it is not a luxury, it's a necessity. If you are a working person, it makes a world of difference. Thus, though you pay a little more, you get a lot more advantages. In conclusion, they have a significantly improved postoperative visual incomes. And the newer and more advanced techniques mean that the spectacle independence, which is something you are trying to sell to the patient and for which you are charging more, is achievable, and you get better visual incomes after cataract surgery. Thank you for your attention.
Thank you. Thank you, Dr. Keki, for your wonderful inputs. So you could stop sharing your screen. So when we try to compare Indian multifocal with an important multifocal, we've all come to understand that the Indian market has really soared high. The metrics on which we measure would be, besides defocus curve, we need to look at the contrast sensitivity, the modulation transfer function, and the point spread function. So I have a question to all of you. What would be your selling point? This question is addressed to the expert panel. Anyone you could take it. What would be your selling point when you're trying to convince a patient for an Indian multifocal against an imported multifocal? Anybody? Do you have to take specific names?
No. Well, basically, I try and tell the patients that you will get a good quality of vision with the Indian lens. There's no question about it. The Indian lenses have over the number of years evolved significantly, and they're pretty good. But still, It is that 19-20 farak. If you want to really get the finest clear vision, go for the imported lens. It will give that to you.
So, Dr. Chitra, I think it is really a question of a person being convinced from within. That is the ophthalmologist. By far, the patient, at least in my experience, once a patient comes to you for getting a surgery done, he has innate faith in you as to what you are suggesting. So they don't really, until of course they have heard of something from some place which they have about certain lenses. There are enough Google searches and people do read about things. The only problem I would say is that India has really not come out with path-breaking technologies over the last several years because of you can see what the state of the medical affairs is today. And similarly, it is the same state which is there for research. So if we talk of fundamental research, Indian companies have really not done fundamental research. They are very good at doing the products which are off patent or which are now available in the market. I have personally been involved with trials which have been done for Indian companies, and I am involved with trials which are being done by FDA by foreign companies. The intensity and the tightness of the trials which are done in Indian circumstances, not for FDA US, are significantly different. So the rigorousness with which a product comes to market is very, very high when you are looking at the foreign products once they are launched in say US or even in Europe. The strictest I think is the US FDA, which is there. The problem that comes is that, for example, let us look at the aspheric technology. That never got introduced in India. It is a copy of what is there. If you look at the achromatic technology, that was not. If you look at the EDOF technology, so there are enough and more technologies. If you look at the IOL technology or even the toric, which gets approved elsewhere and then comes to India. So I would say that once there is a gap of 5-7 years between a technology that has been used elsewhere and then as we keep on, I would say, copying those and become more and more perfect there is absolutely no problem. So initially there is a hesitancy which is there. There are very few companies involved which invest a lot of money for Indian ophthalmologists to do research on their products and to come out with clinical impressions as to what it is. If today I have to get the outcomes, there is one large trial, say for example, of Arvind for the toric IOLs, which is there. But if I have to do it for the other intraocular lenses that are being sold in India by Indian companies, I don't have data, comparative data, to say as to the stability of a toric IOL. Similarly, there is very little published data that is available for a lot of Indian companies. So every surgeon has to actually run it himself or herself to be convinced here that what we are putting in the patient is good. That is the only problem. If we get enough data and if we get enough people having used it and then come to the market by rigorous trials, then this problem of the confidence in a surgeon to go in for because you specifically chose a topic of premium IOLs. Premium IOLs, the kind of scope for error is very little because you have to be bang on to give a bang on result. So that is the only hesitation which is there. The lathe technology or the machines, etc., now are pretty standardized of making the sterilization process, etc. But if you go to a plant, I have been to plants for manufacturing IOLs in India, and I have been to plants of manufacturing IOLs overseas. I think in some plants in India, the SOPs are not fully followed. There is a difference. There are excellent plants. I have visited, say, Orolab also. They have an excellent plant. I wouldn't name the other one where I went, where it was basically reasonably wishy-washy as regards the sterility, etc. So that is the only reason which is there. But prices-wise, yes, that is a big advantage. So it's a question of you going in with some, like Keki sir talked about, I don't know, BMW versus a Ciaz or whatever it is. It's a question of having all the bells and whistles, paying a little more for it, or maybe going for something which will serve the purpose of an individual without the bells and whistle and paying less for it. So I think it's an individual thing, and it's how you feel, whether you are doing any harm to the patient by implanting the lens or not. That is your conviction which is there. So that's about it. As I would wish to say, both have their merits to be done, but path-breaking research technology is still not there, which India is doing. India is copying technology that has been evolved overseas.
Namrata, that was a good answer. Namrata, I want to ask you one thing. In context with my next question, you can give your answer. If a patient has significant astigmatism and he can either afford a imported hydrophobic acrylic or he can go in for an Indian toric hydrophilic. Now, which would you suggest to that patient? He has significant astigmatism.
Obviously, Chitra, imported hydrophobic acrylic would be the one which I would suggest if the patient can afford it. And I think cost is an issue. Cost is an issue.
Namrata, she meant whether you would choose a toric, Indian toric versus an imported monofocal, non-toric.
That's what I'm asking.
No. I would choose a imported toric. I would not choose a imported monofocal.
You don't have that
or
choice.
a Indian toric. Yeah.
No, you
I
still
added a third choice to it, Chitra. I would choose an imported toric to it. I will not, choose a Indian monofocal or a imported toric, or a imported Indian. I mean Indian toric.
Gaurav?
Go in for the best only, because I believe and I completely agree with Dr. Mahipal sir that Indian companies have not spent enough on their R&Ds. Whatever literature is available, whether it is from any institution, it is retrospective. It is not prospective, and it is not multi-centric. It's not involving so many centers all over the India. So we never have that robust data which we have, for the imported lenses.
Yes, that is definitely a very strong thought which has to be kept in mind. Gaurav, as you had got my question, if you were caught with a patient who can afford only this much as a package, would you suggest an imported monofocal for him, or because he has significant astigmatism, would you suggest an Indian hydrophilic toric?
I do it all the time. It doesn't have to be hydrophilic Indian toric. It can be hydrophobic Indian toric as well, which I would definitely prefer, and they are very affordable. Yeah. And I don't mind immediately when astigmatism is significant, I will, counsel the patient and they will readily agree. And I think they do extremely well. So I used to be a doubter till few years back about Indian IOL technology. There would occasionally be refractive surprises. There would be occasional, quality issues. But over the last few years, I've seen that the Indian IOLs are doing amazingly well. And I don't hesitate to use Indian lenses whenever a patient cannot afford, be it for phakic lenses, be it for torics, be it even for multifocals. Of course, I would not jump for a lens which was recently introduced. I'm quite careful about that. I don't like to experiment with new introduced stuff, right as soon as they get launched and they ask you that, you want to use this and do the trials for me. I end up being a little scared of those. But once I have enough feedback, I would not hesitate to do it. Been pretty happy with that. Of course, the bulk of my practice is still all premium imported lenses, but I don't hesitate to switch to an Indian lens whenever required.
So Chitra, just to add a little bit to it, I would rather compromise, on the blades and have Indian blades and not imported blades. Would rather do Visilon rather than using Helon. But I would still counsel the patient to spend a little more to get the best lens, at least in his eye. So that is why I said I would counsel him to spend a little more and go in for an imported toric IOL.
Namrata, unfortunately, it's not a little more, it's often a lot more, and it keeps the technology out of the reach of many of our patients. I do agree that, innovation has not been a strong point as far as Indian companies are concerned. And I must confess that I use a lot of imported premium intraocular lenses, have been involved in multi-centric trials as well as individual trials. And nowadays we are doing it for Indian companies also in a much smaller way. But at the same time, just because the data is not available, not using Indian lenses is something like saying that we won't use drugs off-label, because the companies have not conducted enough studies. I mean, obviously, the international companies, the well-known brands that Dr. Keki was alluding to, have been approved in multiple centers across the world, in the Western world, where far more stringent criteria are there. But having said that, our Indian companies have mastered, quite a few of them, not all of them, have mastered the art of creating a good copy, and because of which it becomes affordable for our younger surgeons, the patients who cannot much more. So obviously, today multifocal intraocular lenses and toric intraocular lenses, I would not even call them premium. That's something that should be incorporated in every cataract practice. And obviously, that's something, even though we would like to offer the very best to each one of our patients, it may put it beyond the reach of many of our patients and many of the practices. The fact that we have this kind of a choice, an Indian choice, along with an imported alternative, obviously allows us to offer this advantage of these lenses to a wider spectrum of patients, carefully choosing. Having used these lenses for the last 4 or 5 years, I think in our practice about 30-40% is Indian intraocular lenses, premium intraocular lenses. I find that these results are reasonably comparable. Even though in a very demanding patient for whom cost is not a criteria, I'll still go for an imported lens.
Thank you very much. We have more questions, but we have to move on. Our discussions have to be very brief because there are so many wonderful questions I wanted the expert panel to answer.
Dr. Chitra, 1 second. The proof of the pudding lies that how many ophthalmologists have got Indian lenses in their own eye done? Because they come and they say,
affordability is a criteria. Hopefully,
so that's what I said. The affordability, if it's a question of affording.
The difference is not too much, Ramamurthy, between
3,000-4,000. For example, if you take an Indian toric hydrophobic, it might be 3,000-4,000, and the other maybe 10,000 or 9,000-10,000. So it's not something, because it's a lifelong thing. So what I'm saying is that the Indian ophthalmologists who come for their own surgery to me, they actually dictate कि ये डाल दो सर, या ultimately they say कि ठीक है जो कुछ भी है, we say the offer. None of them have said कि भाई मेरे को ये lens डाल दो. Till date, I have not. So that is where the proof lies as to what exactly you feel is good for your own eye. That is all that I'm trying to say is the situation. And even for the...
I don't think we should leave behind with an impression that...
I don't think the debate can go on now because we have lost half an hour on the first topic. It has been conveyed, and I do believe that Indian multifocal do have a big role to play in our Indian market. And because we are able to reach out some multifocality to our patients, if not the most premium. Going on, I invite Dr. Harshul to go on to introduce the next team.
Thank you, ma'am. Yeah, thank you very much, ma'am. So once again, on behalf of ARC, I welcome all the honorable expert panel and our esteemed debaters. So it is said that there are no tough opponents in debate, but only tough issues. So one such tough issue is when a 60-year-old patient with +3 diopter of refractive error and a clear lens comes to you. So would you go for a presbyopic lens exchange and premium IOL implantation, or you would like to wait for the cataract to develop? So this will be debated by Dr. Arulmoji Varman, who is one of the pioneer in Indian ophthalmology, heading his very popular UMA Eye Clinic at Chennai. And up against him is Dr. Madhukar Reddy, who is a very prolific cataract surgeon with a great practice in his Drishti Eye Center in Amirpet, Hyderabad, and who holds the vision that the cataract has to develop before he undergoes the surgery. And so first, let's hear it from Dr. Arulmoji Varman. Over to you, Dr. Varman.
Thank you, Ashok.
Mr. Sunil, watch the time, please.
And thank you, Chitra, for asking me to speak on this topic. Chitra, when you introduced the whole program, you said this is controversial. You have 10 topics that are being debated. But I think this one is the least controversial. It's just an open shut case. You have a 60-year-old +3, it's premix. Let's see, there's no controversy here. I'll digress a bit here. Dr. KK missed out an important point. Atishwar waxed eloquent about the Indian lenses. But when he put up his last slide, you had his hospital up there, and what was parked in the car park was a BMW, not a CS. Let's go now. Now, what happens to a person who is 60? He's already 60, he's into his 6th decade and having a lot of other issues. But then you give him a +3 hyperopia. He can't see distance. He can't see near. He wakes up in the morning. He wants to see the time. The wall clock is not clear. He looks around and looks at his watch, or today we are looking at our cell phone. Lo and behold, he can't even find the cell phone. He's blind as a bat. He's got to flumble around and flounder till he finds a pair of spectacles, puts them on, maybe knocks over. We'll just think that this is a male, poor old male, 60 years old with +3, and he knocks over things on the table or the side table, and then wakes his wife up and gets fired. He's got to go and brush his teeth. He can't see the toothbrush without his glasses on. He can't shave, he can't do a damn. So you have this person who's now visually incapacitated, one. Two, there are enough and more studies that show that there is a progressive reduction in the anterior chamber depth as we age. Simple as that. This is just cannot be questioned. This has been there with all the races across the country, across the world. There is a very clear relationship between the refractive error and anterior chamber depth. You're a myope, you have a deeper chamber. You're hyperope, you have shallower chamber. You keep growing older, the chamber gets more shallow. So we also have correlation that shows correlation between shallow and anterior chambers and iridotrabecular contact. In other words, angle closure. Very clear. There are umpteen number of studies that will tell you if you're hyperope of 3 and you're 60, you already have chances of an iridotrabecular contact, and you're a prime candidate for an angle closure somewhere down the line. This is increasing incidence of angle closure with reduced AC depth and axial length. Axial length reduces, your axial, the anterior chamber depth reduces with age. The lens keeps getting more thicker as we grow. There's one of the parts in the body that keeps growing, just like your ear and your nose, the lens keeps growing. So that keeps getting bigger and you have less and less space. So we will have definitely, Madhukar will tell you that let's do an YAG iridotomy and this guy is going to be fine. There are studies that show you a minimum of 28% or even sometimes more proceed to angle closure even after a YAG PI. So doing a PI is not going to save you from angle closure or a slow chronic angle closure, acute angle closure, or going in for an angle closure glaucoma. 30% of your patients are probably going to progress into that in spite of the PI. On the other hand, you take out this 5 millimeter thick natural lens and put in a 1 millimeter thick artificial lens. Your whole anterior chamber, the anterior segment becomes absolutely normal. It widens out, completely takes away the chance of any kind of angle closure. So you're now saving this person not only from the chance of angle closure or glaucoma, also giving him much better vision. When we'll also talk, my opponent, Madhukar, will also talk to you about risk of RD. Risk of RD is more with longer eye lengths. A +3 is probably having a shorter length, the chance of RD comes down. If you have studied the periphery of your retina before you do the surgery and continue following these patients up, the chance of RD is definitely much lesser. I won't even get into the chances of endophthalmitis. With today's technology, with the kind of technique of maintaining sterility that we have in our instruments and in our theater, it's not very difficult for us to achieve less than 1 in 10,000 endoph in the long run. With such low incidence of endoph, I think we shouldn't even be discussing endoph as a possible complication. RD after phaco in shorter eyes is extremely less, as this graph will show you straight away. The procedure is very simple. All we need to do, this is something that you can probably, you have a clear lens. The lens is not going to be very hard. Just going to make it so simple for anybody who's a reasonably good phacosurgeon to do a great job with least difficulties. You're not going to go and damage endothelium. You're not going to get a PCR that easily. You're not going to have any other issues. This is going to take you hardly about, actually for an experienced surgeon, the whole surgery start to finish will probably about 4 to 6 minutes. You have a nice soft cataract, but you do have a nice good nucleus in the center, which will definitely break. You can do a chop if you wish to. And the rest of the cataract just comes off in a matter of a minute or minute and a half. That leaves you with the freedom to implant an appropriate advanced lens that would take away the dependence on glasses of this gentleman and give him good vision. We'll come to the high accuracy of calculations. So the Keiki put up this web source IOL master, the technology that look after absolute accuracy. The performance of the IOLs that we have today, the trifocals, the quadrifocals, the EDOF plus trifocals that are in the market are so brilliant. The quality of vision is clear over all distances. The clarity is very good. The contrast sensitivity is simply excellent and with minimal photic phenomena. So what do you offer to these patients? You give them the relief from disturbance of hyperopia, you give them natural vision, and an absolute relief from angle closure down the line. What are you going to gain by waiting 5 years? Nothing. You're only going to wait till the patient or the person develops cataract. In the meanwhile, the risk of this person developing angle closure is going to be very high. He could go in for a harder nucleus, making surgery more difficult. So Prelex is the way to go in hyperopia in the 6th decade. There's nothing else. And I would thank you for listening to me. Let's listen to now Madhukar.
Thank you very much, Dr. Verman, for putting your side of this story. So now let's move on to Dr. Madhukar, what he has to say in this situation. Dr. Madhukar, can you please share your slides?
Yes, please.
Yeah,
Okay,
we can
see my slides, Harshal?
Yes, we can see that. Please go ahead.
Okay, thank you, Chitra and ARC, the whole team, for inviting me for this wonderful debate. I enjoyed Arul Mozivarman's talk, and let me put my story of this topic. Next slide, please.
Can you?
Okay, I'm through. So coming to refractive errors in the general population, about 40% are hyperopes in the 50 to 60 years age group. And then 30% have been shown by studies in the 60 to 70 years age group, and 30% hyperopes more than 70 years. This shows us that as we age, there's a nuclear sclerosis, and slowly you're going towards a myopic side, which all of us know. So this is the epidemiology part of it. And that's a huge percentage of our population. If you say 50 to 60 years or 60 to 70 years, so 70%, 40%, 30 to 40% are hyperopes. So as per Azul, my good friend Arul, he says that all of them have to be knocked off, their lenses, not the cataracts. So again, we come to the debate. Yes, it is 60 years old and plus 3 hyperope. I'm 60 years old, I'm plus 2 hyperope. Why not me? So as Arul said that I fumble around, my wife fires at me, but nothing of that sort is happening. I'm enjoying. I'm looking good with my glasses. In fact, I look better with my glasses on rather than without my glasses. So I would prefer to wear my glasses and not have a cataract done at now. And then comes again the debate, why not 55? Why not 2D? Why not 40? And why not 1D? So that's what's happening. And not everybody develops a cataract. My dad and so many of my friends' dads are still hanging around without cataract surgery in their 80s. And all of them are doing well. And my father refuses to undergo cataract surgery. He's 89 and he's saying well. So my concern, once this debate comes in saying that 60 and plus 3 or plus 2 or whatever, so now you find that in your practices, a lot of people come, they don't tell you what their problem is. They'll say, doctor, what is the problem? I'll say, yeah, you have cataract. It's plus 1 or plus 2. And then with a change of lenses, we'll be able to see. And then slowly come up with a story. I went to the other practice. They said that you have cataract, and if you don't have it done tomorrow, it will burst. I'm sure all of you have gone through this thing, and I don't know what to say. I'll have to protect my colleague. I just say, yeah, your cataract is starting, and then if you wish, you can have it. The patients are not told anything. They don't have an idea what's happening. And they're just told that because they went in for some refractive error and they're told that to undergo cataract surgery the next day. I think that's not right. I'm sure all of you agree with that. Then cataract surgery, as all of you know, as long as it goes on fine, it's nice. But suddenly you see a hypopion, and then all of us panic. And please believe me that, and all of you understand that all of us have endo-offs, all of us have complications, but we put them under the table. We don't want to acknowledge them. We don't want to publish them. We don't want to show them, and then put them into each one room and send to each different colleague if you have a cluster. So, I don't think we should take it so easy and just be cavalier attitude, take the cavalier attitude and say that, yeah, cataract surgery, it's so simple, 5 minutes, 10 minutes job, but it's not right. And all of you know that if something goes wrong, it's the end of your story. there are over corrections and under corrections. You feel that every time it's hunky-dory, that everything will be 0 and the patient will see perfectly. But suddenly there'll be +1 and -1. They'll come up with a long face and say that, doctor, you promised me without glasses, I can't see the last line, I can't see this last letter, and I'm having this trouble and that trouble. So that's also a problem. And there are many other side effects of cataract surgery, as you see, inflammation, and then multifocal IOLs. You find that there's so much chair time you have to give, and at the end of all of it, again, the patient is not happy because they say that you're not seeing the last line and your surgery is a failure.
1 minute left.
Yeah. And then the other aspects of ptosis, PCOS, dry eyes, and retinal detachment is less, but it's still there. That risk is there. And then the floaters, implant decentration, wavefront abnormalities, all of them are there. If patient is used to his natural vision lifelong, and let him enjoy it as long as possible. And then the story of diabetics. As you know, what happens? About 20% in the age group of 50 to 90 years are diabetic. And then what happens 10 to 20 years later? And now lifespan has increased so much. And 17% of all the diabetics in this 50 years age group develop diabetic retinopathy. And my retinal surgeon says that it's such a difficult thing, lasering retinas through a multifocal lens. So think of them. Multifocal technology is not appropriate, less contrast, more glare and halos. So be careful about that. And the legality, if you in a potential 6/6 patients, if you're operating, something goes wrong, we don't know how will a judge us. And then as an ophthalmologist, first of all, take the question that will you have a multifocal lens implanted? And if so, whether if you don't have a cataract, would you get your cataract surgery done? Please think about it for a minute. Thank you.
Thank you very much, Dr. Madhukar, for putting your points very strongly. So in all intellectual debates, both sides tend to be correct in what they affirm and wrong in what they deny. No? So we need to take a neutral point of view from our expert panel. I'll request Dr. Partha Vishwas, Chairman Scientific Committee, to please give his opinion on this situation and what would he prefer.
Thank you very much, Harshul. It's been a wonderful debate, and but the spice of the debate was missing, Madhukar. And Arul sir, I mean, a little below the belt is also can be hit. Having said that, what is very important is the ethics of the surgery is important to the desire of the patient undergoing the surgery. It is important. And that would be possibly the final judgment where the surgeon has to judge, yes, this 60-year-old may be crippled with arthritis, may not be able to walk well, may be finding difficulty with glasses, requires a cataract surgery. The personalized decision to do a cataract surgery with a +3 and a 60-year-old, again, if he's able to tolerate his glasses well, he's happy with his glasses, why suggest a cataract surgery? So a balanced approach, and that's what all of us as surgeons, I'm sure we do. For debates, of course, we take sides and we bounce on each other, but that is the rational approach, I would say.
There is this concept now which is evolving about dysfunctional lens syndrome, whereas it's in the early 40s, it's presbyopia, and then the incipient lens changes would set in, and later on early lens changes. So anything below 7, based on the features like the contrast, sensitivity, internal aberrations, and pupil dynamics, this concept has been evolved. And if we actually look at some of these 50-year-old with a cloudy lens, these are, and if he is a hyperope, we can, and on the best of platforms like a femto cataract platform or the best of multifocals, which was so eloquently discussed in the last thing, I don't think we need to be so worried as Dr. Madhukar pointed out, but then that was his point to debate on. I have a question. What would be your cutoff for implanting phakic IOLs in some of these younger patients? How rigid are y'all about the upper age limit? Dr. Mahipal?
See, basically, it depends between whether a patient is a myope or a hyperope. If a patient is a hyperope and a patient has gone into the presbyopic age, I would prefer to go in for a presbyopic lens exchange rather than go in for a phakic implant. The second thing which you rightly said is the dysfunctional lens syndrome. So if you have an access to an eye trace, you can actually look at the dysfunctional lens syndrome as to whether the person is having what amount of scatter, how is it affecting the contrast, etc. So under those circumstances, if that is there, then you would wish to again go ahead and not do a phakic implant, because as it is, it's a question of doing 2 surgeries in a patient. If you do a phakic implant, sooner or later that person will develop a cataract, even though the incidence may get aggravated. So that is it. So if it's a high myope, I can go up in the age a little bit, maybe 40, 45. But if I have a patient, even if he or she is a myope and the patient is 50 plus, for hyperopes, I would keep my age as 40 plus, and person has presbyopia, I will go in for a presbyopic lens exchange rather than going in for a phakic implant. And for myopes, if they need, maybe 50 would be for me to go in for lens exchange, cataract exchange.
I think Dr. Madhukar said it very well in the last slide. How many of us, I'm sure a lot of us here are over 60, not me, but how many of us will, want to get a presbyopic lens exchange? And again, like Dr. Maipal sir said, the test of the pudding is, the same, that how many of us, how many of the ophthalmologists would want that to happen?
Yeah, but you don't see many hyperopes out here sitting. So, Namrata, that's a question which is directed. There are very few hyperopes among.
Last question I have before we go on.
So Pankaj says that he's a hyperope and he will not have. So, Dr.
I will
Pankaj
ask Arul Muhivarman to answer this question. Arul, what would be your preferred choice of IOL-ARC calculation in a short eye, not just +3, a little shorter eye? Because here you are promised a prelex to this patient to the best of results. What would be your go-to formula? Would it be Barrett's, or would you have different formulas for shorter axial length or post-LASIK eyes?
Yeah, okay. For the post-LASIK, it's very easy to answer. You go for the LASIK, post-LASIK formula that are available.
Which
Holiday
one?
has one. Barrett also has one. I'll try both and I'll look at it. But particularly, I would want to use laser-based system to measure the cornea as well as axial length. I use the IOL Master 700, which is brilliant. And in the very short eyes, extremely short eyes, half a cube works better.
Ramurthy, you have anything to add before we go on to our next team?
+3, yes, I would like to go ahead with the Barrett Universal 2 with the IOL Master 700, which is incorporated in it. It works well. And as you mentioned, cataract is not something which occurs overnight. In a 60-year-old, already there's quite a lot of higher order aberrations. The spherical aberration is significant. It's a much thicker lens. So the quality of vision is quite poor. In these cases, definitely a clear lens extraction can be anticipated. And in line with what we discussed in the earlier topic, this is one case where I would definitely go for the best of multifocal intraocular lenses and imported lens. The test of the lens and the test of your surgery is really satisfying a clear lens extraction patient. So no compromise on this type of surgery. But if you do the best of surgery with the best of lenses, you often end up with very...
Paucity of time, we shall come back to discussions based on the time we have. Can we watch Entod's video before I start introducing the third team? Mr. Sunil? Mr. Sunil, are you there? Next team to be will be by Dr. Suhas Haldipurkar, who is a founder, director of Lakshmi Eye Institute and the chief trustee of Lakshmi Charitable Trust, a pioneer of phaco surgeries in our country, a superb surgeon who is going to tell us something interesting. Why LRIs do have a role to play in low grades of astigmatism. And he is going to be countered by our superb debater, Dr. Partha Vishwas, who is going to clearly tell us why LRIs do not help at all. So on to you, Dr. Suhas.
Yeah.
Can you share your screen? You have to share your screen.
I'm doing it.
Mr. Sunil, are you there?
Yeah, ma'am. Should I play it now?
Yeah, play it now. No, you seem to miss some this time. Please be there throughout. Thanks to our sponsors who have been enrolled in all our ARC ventures. So let's hear from you, Dr. Suhas. Could you share your screen?
Yeah.
That green button below, share screen.
Done that.
Doctor, first open your presentation, then do the screen sharing.
I have done it. I think he has to, he has not given away his shares.
You can, sir. There is no limitation, no restriction on anything. On the Zoom window, there is a green button, 6 o'clock, share screen. Just click on that.
No, I know, I have done that. It doesn't seem to happen here.
Sir, is it a walkover?
Come on.
No, it shouldn't be, Partha. The debate would be great for you if Suhas makes his blunders. What is happening? Have you opened your presentation beforehand?
Yeah, I have kept it open.
Can you?
Are you able to click the share screen button on the Zoom window?
Are you able to see it?
The third person has to stop sharing.
Yeah, that's what I thought.
Yes, he's still sharing. Ask him to stop sharing.
Who's stopped? Who's sharing?
Then nobody's sharing, sir.
Nobody's sharing.
We still see support at 0.
No.
The support team is still sharing.
Sunil, maybe you should stop sharing.
Arul is correct. Arul is correct. What is saying?
Yeah, I'm always right.
Arul, you are definitely right.
I just
No,
tried.
sir, I'm not sharing. It was Mr. Pankaj who was sharing.
Yeah, no. I just tried it, and it is sharing properly.
If the sharing is on, there is I have stopped sharing long time.
Okay, Dr. Suhas, can you share your screen now?
Yeah.
Good topics, lot of discussions possible. We should getting delayed.
Sharing, definitely.
Yeah.
I was sharing. Dr. Pankaj would not have been able to share it.
Yeah, exactly. And I was just doing a check whether it is enabled or not.
Mr. Sunil, could you help Dr. Suhas in the interim? Do we ask the opponent to start?
I just have one question. Which computer do you have, Dr. Suhas?
Mac.
So in Mac, you have to allow the computer permission to share. In the settings.
Yeah, I think Sir has done it so many times before.
Maybe it's a new computer now.
No.
So maybe you log out once and join again, sir.
Dr. Suhas, can you mail it? I will play it from my end.
Pardon me?
Can you send it to me? I will play it at my end.
Maybe I would do one thing. Dr. Partha, could you hold on? I'll ask the next team to step in.
Yes.
Because I think it'll be enjoyable only if two of you talk against each other. Harshul, can you introduce the next team?
Yes, ma'am. Yes, sure.
Yeah.
So the next match is between Mumbai Indians and Chennai Super Kings. And topic is whether digital markers are essential for toric IOL implantation or not. So Mumbai Indians is represented by Dr. Abhijit Desai, who will tell us why digital markers are essential for toric IOL, as DRS system is essential for LBW decision in cricket. Dr. Abhijit, we all know, is heading Soham Eye Care Center. He has a top-notch practice in Mumbai for over 2 decades, a brilliant surgeon. And Chennai Super Kings is represented by Dr. Ramesh Dorarirajan, a great academician heading Sundar Eye Hospital at Chennai, and who believes that conventional marking system like conventional umpiring method is just fine for toric IOLs. So Mumbai Indians to go first. Dr. Abhijit, you all set?
Herschel, are you
All
in
set, all
India or
set.
Bahamas?
3:30.
Dr. Abhijit, yeah.
Abhijit,
Can you
please
start
start.
sharing?
Yeah.
Yes, we can see that.
Please stick to your 5 minutes.
Yes. Thank you, Chitra ma'am. Thank you, Harshul, for inviting me for this debate. So the debate is basically whether it's essential, 1 point, and for the refractive accuracy. So that's the second point which I would actually talk about. We all do cataract surgeries. We all are doing topical cataract surgeries. We are doing high-end or premium IOLs, multi or monofocal toric IOLs. So definitely we are doing refractive surgery here, and we would want the patient to be very comfortable and without any refractive errors. And as you all know, the most common cause for an unhappy multifocal patient is a residual astigmatism. So don't we all do refractive lens exchange as well? Definitely, and obviously there is no doubt about it, and we need to be very accurate with such patients. So what are the disadvantages of a manual marking? We get a smudge. Positioning of the head may be an issue. Accuracy is definitely an issue. There would be transcription errors. And yes, if we have to stick to our surgeon's egos, I am God, no one is as accurate as I am, that would be the biggest problem that we would be facing. So there are multiple kinds of markers which are available. Each person decides which marking system he decides. But the disadvantages list goes on and on. So when you have a long list of 80 IOLs, how many markings are you going to do before entering the theater? Then you would depend on others for marking. So you're not sure whether the accuracy is good. The wearing out of the dye is a very important issue in in a high number of cases. There are people who do marking with needles on the slit lamp. Such patients sometimes develop epithelial damage, abrasions. You can actually have recurrent corneal erosions also in these patients, and you wouldn't want these kind of things in your premium IOL or a multifocal toric. There is no highway mark in a manual marking, so it doesn't allow the parallax to be taken care of. And please tell me, how does one place a IOL on 103 degrees manually? No one can. Definitely you're going to be in jumps of 0.5, and even with that there is going to be an error. There is this study which I would like to quote here, in which this is from Japan, and they actually measured your reference marks on the Varion, whether the reference marks themselves were right, and they were nearly off in many of the cases by nearly 10 degrees. The most important thing, I work on Varion, I don't have any experience with the other marking systems, but it negates the head tilt. And the mathematics is definitely there. 1 degree of error is a 3.5% error in astigmatism under correction. 3 degrees is a 10%, and 30 degrees is a total loss of toric correction. So these are the various studies which have told us that the lateral head tilt as less as even 5 degrees gives you a intorsion or extorsion up to 3 degrees, and can vary up to even 17.5 degrees with a 25 degrees head tilt. This is a small video which I would like to play because
You got muted, Dr. Abhijit, suddenly. Can you
so this is a small video to just show the scientific evidence. So this is a lens star which we've done with a head tilt of around 10 degrees. And the same patient has been registered on Varion as well, and we've done the manual marking here. And as you see, even with the manual marking, when you're going with the left hand, sometimes you may smudge the eye when you're doing it, especially over the nose. Now, during the surgery, we have done the markings as per the reference marks and not as per Varion. But luckily, we have done the Varion registration already for that patient. Now here with that smudge, you already have an error of around 1 to 2 degrees. And now when I have put on the Varion, you can see there is a 10-degree difference between the incision site itself. I go as per the Varion. We would just go forget the CCC part and go to the. So now I'm implanting the IOL on the reference marks which I have made manually. Okay. And after this, I'm going to switch on the Varion and see whether my placement is as per the Varion. I'm off by 10 degrees. So what an image guidance system does is it's going to take up all the markings on the blood vessels on the limbus and it's going to register the limbus. So even with the head tilt, it's going to negate the head tilt and actually accurately measure your steep axis. And that's going to increase your accuracy by many folds. Now, if this patient would have been a high astigmatism with a 10-degree misplacement, you would have been left with a 0.5 to a 0.75 error as a residual, which would have been really not, it wouldn't have gone well with the patient. And now this is the actual reading with the head straight. So yes, definitely, if you don't accept a new invention, you wouldn't reach where we are. And if man did not invent a wheel, definitely we wouldn't have a car. So I choose to have accuracy, consistency, and dependability all the time. Thank you.
Thank you very much.
Thank you, Dr. Abhijit. Yeah. So now over to you, Dr. Ramesh. Why do you feel that conventional marking system works well? Yes, Dr. Ramesh.
Thank you. Are you able to see the screen now?
Yes, yes.
So we had a super presentation, but I have a feeling that he didn't spend much time learning about manual marking. So he believes that digital marking is the best. The experience of all the surgeons in the world is that there is not much difference between manual and digital marking when it is done right. And we know that for excellent results, we need to measure right, we need to do calculation right, and the right calculation for a toric lens is not what is present in the Alcon site, which is an old 1.5-year-old version of Barrett's, but rather what is present in the AP-ACRS Barrett's toric calculator. Then we need to do the marking where there is a small difference. We'll come to that. And we need to have a rotationally stable IOL. And if you're doing manual marking, you can choose a brand that you want to use. So let us see a wonderful paper presented, published a few months ago by many of the mentors in the group here, Dr. Ramurthy, Dr. Chitta Ramurthy, Dr. Shriyas, Srisha, and Gitan Shah. And their conclusion is, in their series of manual as well as digital marking, both are equally effective. There is only one systematic review from Greece, from the Alexandria University, where they have gone through 21 good studies, and they have come to the conclusion that conventional manual marking, if you want to do that, the conventional marking techniques are not as good as the digital marking systems. So they measured various parameters, and the difference they found was an up to 2-degree better accuracy is found in the various studies which they did. If you are doing if you're using a Varion or a Callisto. Now, what does this 2-degree difference translate into? It translates into a 6% loss in effectivity, and on an average 0.1 cylinder. You and I know that a 0.1 cylinder cannot be measured, and it's a theoretical number. I agree, it takes time, it takes more skill, and the markings can smudge, especially if you're using the ink. Don't do that. Success needs hard work, and there is no easy way, and sometimes the easy way is not the best way. I do the needle marking, and you do need to develop certain skills. It doesn't smudge, and you can get 103 degrees if you try. It takes a few months. But I have beautiful savings. Look at the estimate that I got for going markerless with my current Lumira. I got an estimate for 36 lakhs plus GST. This quotation came a week ago. My dear friends, there are many of us here in India for whom it doesn't matter. 36 lakhs doesn't matter. And they prefer to tell the time with a Rolex and not with a cell phone. That choice is theirs. But for most of us, this is a large amount of money. And we know that studies and our own experience shows we get great results with both methods. Here are a few of my last month patients. Here's a T2, first post-op visit 6.6 partial. Under the T4, first post-op visit 6.6, a T3, first post-op 6.6 partial, a T6, first post-op 6.9, a T3, first post-op 6.4. See, we see this day in and day out. If I was getting poor results and if I had trouble, I will not be continuing with this. So you do get great results with manual marking, and I have extra cash in the bank. It's a lot of money. You can go for nice holidays, several holidays. The truth is there is not much difference in the outcome if done properly, but in digital marking as well as manual marking, all the studies and our experience says this. So I choose to pay my staff full salary despite slowdown, and the next 1 year is not a problem for me. But you can choose to tell the time with your cell phone or the Rolex. You can take the easy way or you can take the hard way. It's your money, it's your choice, but you'll get the same results. Thank you.
Thank you very much, Dr. Ramesh. Yeah. So both the debaters have done very well. Now let's hear it from Third Empire. I'll request Dr. Gaurav Luthra to please give his opinion whether to go for digital markers or not, and save that money and utilize it somewhere else.
Thanks, Arshul. And very interestingly debated by both participants, and both have very valid points. So I would have probably done 5 years of marker with the marker and then another last 5-6 years with the markerless system. So I can tell that both work extremely well. And while it is there is nothing lacking in doing surgery with the manual marking system, you can still achieve about 90% of what you might achieve with the markerless system. Yet there's no doubt that when your numbers are bigger, if you're doing maybe one toric in an OT or maybe 1 or 2, you can easily get away with the manual marking system. If you're doing 5 or 6 or 7 torics, and if you want to increase your toric practice as well, it makes a huge difference to go markerless. I've been using the Virion for almost 5-6 years. It's made a huge difference to our toric results, our ability to do torics. So I think for those who have a practice which has predominance of toric IOLs, or they want to do predominant toric IOLs to correct astigmatism, they're very sensitive to astigmatism correction, and they have the numbers, it makes sense to switch to, because time is money and you save a lot of time on each patient when you go markerless, because it comes automatically, it's seamless. Whereas when you do manual markings, you have to dewash in between. You've done maybe 3 markings and then you want to come out. And we had a Virion breakdown for a few days. I had to come out after every 3 cases to mark the next 3, because otherwise they would, kind of wash out. All the same, nothing is taken away from manual marking. It works beautifully well as well.
Namrata, I have a question for you. Yeah. In case your registration failed, which is so rare and next to nothing, it never happens, would you always have a slit lamp marking also done as a safeguard?
I normally don't have a slit lamp marking, and like Gaurav said, it is all about availability. Earlier we used to manually mark, and now because we have Virion and Callisto and Aura, so we now use these systems to do the toric marking. And having said this, I think it is not even about time. One has to be accurate, and we did publish when we compared Virion with the manual marking, and we came out with the results, and that's also published, that there was no difference between the two, whether you did manually or you did on the Virion. So we do not mark manually prior to the digital systems that we have, and generally have 2 systems in place. Aura is always there, and as of now do Callisto and Aura both simultaneously.
I just want one answer from you, Dr. Ramesh. Which would be your preferred manual marker, slit lamp or bubble marker? And in the interim, I would want Dr. Suhas to share his screen.
I think and it's not correct to do a two-step marking. You should do a single-step marking of the final axis. If you do a two-step marking on the slit lamp, there are two stages where you can make sequential errors. So I'll prefer to do a direct marking of the final axis on the slit lamp, which is there in the semisterile area of the theta, and I use one disposable needle per patient. That's it.
Thank you. Doctor,
Shall I-
thank you very much. A wonderful debate. Dr.
Yeah.
Suha, yes.
Over to you, ma'am.
Dr. Suhas, I had already done the introduction, so I want Dr. Suhas to start his presentation.
Thank you so much, Chitra, and sorry for the inconvenience. I know Dr. Pathu, my good friend, must be waiting with Bofors guns to demolish what I'm going to say. But then, well, LRI do have a role for refractive accuracy in low grades of astigmatism. See, LRI is a time-tested and scientifically proven technique, and with better understanding of its functioning, it is more reliable and more accurate today than in the days when it was introduced. Small cylinders have suddenly become eyesores to cataract surgeons, especially when you're doing customized cataract surgery. But not all cylinders can be tackled with toric lenses alone. And that's where the LRI still comes and it can be used as a standalone procedure or as an add-on or touch-up procedure if it can be positioned in that role in our practice beforehand. See, what I talk today focuses on low astigmatism management. It's either 1 or less than 1 during or after cataract surgery, be it with the rule or against the rule. If you look at this slide, these are patients who present for cataract surgery in the age group of 50 to 60. And it's amazing to see almost 36.5% of them with cylinder of 0.5 to 1. Now, this is a large segment which I can easily target with my LRI if the patient cannot afford a toric lens. And the second group in the previous slide are those patients with larger cylinder who, after having toric lenses put in them, sometimes do have some residual cylinder. It could be sometimes 0.5, 0.75. Now, these are another group of patients whom I target with LRI. Next. Now, factors that influencing effects on LRI, either it's a corneal thickness, patient's age, corneal diameter. So finally, the depth and arc length of arcuate incision will be calculated as per the nomograms. Just to refresh, when a deeper cuts will definitely give you more flattening and more next slide please. More central the cuts, more will be the flattening. Now let's look at this case. Now I have used Varion that is not recorded here. You do not see Mendy's marker here, but I'm going as per the Varion. It's always better that you do your LRI beforehand. You measure the peripheral corneal thickness. You use a variable diamond knife, and if the nomogram tells you to keep your cuts away from your main incision, you can accordingly do it. And at the end of the surgery, you can just flush your groove that is created for LRI, and then you tend to get very. Next, please. Next. So, where do LRIs fit in my practice today? During pre-op workup, if the patient has a cylinder which is more than 1, obviously he goes in for goes in for a toric lens, or if you can't afford toric, he'll go for an LRI. If the cylinder is 1 or less than 1, and if it's with the rule, I would probably do nothing or do LRI. And if it's against the rule or oblique cylinder, the obvious choice is either LRI or a toric lens. Next. Next. But the question comes when you have a cornea with an irregular astigmatism, when you have a corneal scar, when you have asymmetric bow tie, when you have keratoconus, or when you have cases where toric has absolutely little role to play, and these are the cases where LRI has everything to offer, if not in totality, but to a large extent. Next. And this can be easily done by using different nomograms. We have LRI calculator nomograms, in which the popular ones are Napa nomogram and Dono. Both of them you give good results. My personal preference is for Napa nomogram because it takes into consideration the peripheral corneal thickness, and accordingly your diamond knife is set. Next. This is a LRI calculator in which you input your K1 and K2 and the thinnest corneal depth in the periphery, and the program will tell you where the incision should be, what should be the size of your arcuate cut, and what should be the depth of your diamond knife that you're going to use, and what will be the residual astigmatism. Next. So my final thoughts is that it's a simple procedure. Next. If done methodically in small cylinders, it works as good as a toric lens, and the regression is insignificant when you're dealing with a small cylinder. Can be combined with toric lenses or used as touch-up procedures in the post-op period in eyes with a residual cylinder. Can be combined with multifocal IOL packages in low cylinders where cost is already an issue. Thank you.
Thank you very much, Dr. Suhas. That was a wonderful talk. On to you, Dr. Partha. Your attack is look forward to.
Thank you, Chitra. Thank you very much, Chitra and the ARC for giving this opportunity to say that LRIs do not help for refractive accuracy in low grades of astigmatism. Cataract surgery is the new cataract refractive surgery, and I think both of us agree to it. If we agree to this, then we also need to agree that femtolaser, the premium IOLs, and astigmatic correction remains the holy grail, but no LRI. Shortcut methods to maybe please the patient temporarily, I don't think is something that we require. Why I never prefer LRI over the toric IOL? Well, the tissue response cannot be titrated. There can be undercorrection, overcorrection, new axis of a cylinder might come up, and the astigmatism might become irregular. Sir showed the diamond knife manual LRI. Even if it is the flax-assisted LRI, there is a possibility of error, and all these errors can keep happening, more so with the diamond knife. How much to incise? So many nomograms are available on the net, but no one knows it full well. And not a single one is verified. It becomes more of an art than a science, and the artistry of Dr. Suhas Saldipurkar cannot be emulated by every cataract surgeon. This is important. There is a risk to infection, and this is an unnecessary risk. And in our experience, we have published this paper in the IGO, and where we saw that there was an infection in the LRI, and therefore LRIs are not 100% safe at all. Persistent epithelial defect can occur, and a post-operative dry eye is very much strongly there. But the most important factor is the regression. Would you like to offer a temporary solution to the patient? Do they know what procedure that you're going to do, and are they going to trust that procedure, even if it is with a diamond knife or a flax LRI? The Cochrane library, the meta-analysis, has this to say. And toric IOLs probably provide a higher chance of achieving astigmatism within 0.5 diopters after cataract surgery than compared to the LRI. and LRIs can still be qualitatively viable, mean in those cases where toric IOLs are contraindicated. But otherwise, it is a toric IOL which is required. So is LRI a useful tool in itself if astigmatism is not too high, provided cornea is healthy, needs more accurate nomogram for calculation, but it's not accurate, however, may regress over time, may lead to infections? And would you like to offer an imperfect technology with so many ifs and buts if you are not in that grade of artistry as Dr. Suhas Aldipurkar? My Guruji who taught me capsular access in my early days of cataract surgery. But let us be honest. Thank you very much.
Thanks, Partha. That was a great talk. We know we are all challenged by the wound healing response and the regressions which occur with LRIs or with femto laser archway keratotomies, and torics do reign best. But having said that, I wanted to ask you, Partha, supposing you have a patient who wants a multifocal IOL, cannot afford the LRCS platform and the arcuates, and you don't do the LRIs, and he has a 1 diopter of with the rule astigmatism or 0.575 sil of against the rule, what would you do for him?
So
you
here,
don't seem to like arcuates either. I saw that thing you were showing. Would you be using arcuate keratotomy at least?
Yeah. So here we have your situation is one in which the patient wants a multifocal IOL. Now with a multifocal IOL, the patient is already in that category that he's demanding, and he wishes to have something that is going to give him very accurate vision. So here again, an LRI will not be the ideal thing at all. It has to be a toric multifocal if you have to get this patient well corrected, very well corrected.
No, in that you don't get toric IOL in the low astigmatism which I mentioned to you.
0.5, 0.75 is not required. Within one diopters, you can do a toric. We can do a multifocal or a trifocal IOL.
I would want
without LRI. Without LRI.
Expert panel, Dr. Ramurthy, are you there?
Yeah, I mean, I was using limb relaxing incisions, gave it up, and then picked it up again once I got the Varion. I mean, we already published about the results with toric IOLs, but the Varion, one of the major advantages I find is the accuracy with which we are able to place the incisions with a 600 micron guarded knife. And the Varion itself gives the incision size, the arc length of the incision that you need to make. Definitely, it's out of the question if it's more than 1.525 diopters against the rule of 0.75 diopters against the rule of 1.25 diopters with the rule. It will be a toric intraocular lens. These were the lesser amounts of astigmatism where you want to actually debulk the amount of astigmatism, especially with the multifocal intraocular lens. It's different. We are not talking about refractive accuracy, but talking about the reducing the amount of astigmatism these patients have to deal with. I think Suhas mentioned about the variability of the outcomes. One important point he did not mention is the corneal hysteresis. That's the reason it works well in older patients, while in the softer corneas, the younger patients, LRI results are somewhat less. That's why it works something like radial keratotomy. But whenever I'm dealing with small amounts of astigmatism, toric intraocular lens is not a choice, especially with multifocal intraocular lenses. I think it's an inexpensive way of debulking the astigmatism.
And before Harshul goes on to our next team, one last question. If you are going to be doing astigmatic keratotomy on a LRCS platform, would you prefer to do paired or unpaired arcs if the arc is falling on the site of the incision?
Okay, can I take that?
Yes.
Okay, the first thing that I'll wish to say is that not enough work has gone on in the LS-CRS platform till recent past as regards the LRI, the placement, and the nomograms that have to be used. The COS 6 platform which is there, which actually gives you the marking of the steeper axis on its own. That means that if you have it with a Cassini, it will be seen in the OPD and then it translates. And now the Donald-Field nomogram is there where you can alter it accordingly. So a single incision can be done on the opposite side of the incision where you are making the incision, or you can do a paired. So it all depends on the amount of astigmatism. Normally a single incision would be enough, because if you have an astigmatism, as Dr. Ram said, of more than 1.5 or 1.25, you will go in for a toric intraocular lens. But I 110% agree with what Ram said, that there is always a debulking of the astigmatism. The results are good. Our cyclotorsion compensation was not being done in the LRCS platforms earlier. Now, if you have a cyclotorsion compensation, you have an in vivo real-time depth perception that is there, which the OCT gives you, and therefore the results are good. And now there are pre-built Donald-Field nomograms which are there in the software of the version 6, which is there. So I'm sure as we do more studies.
4 o'clock.
Sorry?
No, it's okay.
So it is going to actually improve the outcomes which you have with the LRI. And the second thing is that we are rather apologetic about the possibility of a regression. Even if there is a regression, there is nothing stopping you to go back again and open up the incision, which can be opened, or to create another incision, which can be done subsequently. So LRI, I think, is a very useful armamentarium that all of us should have in our surgical armamentarium. And if you have an LSCRS, I would always do an LRI if I am not using a toric implant. And single is something that I normally prefer. If I have to do bi-arcuate and it is going to intersect with the incision, then I would rather move my incision to the temporal and keep the LSCRS as the bi-arcuate on the steeper axis where I want.
If I may just add on, sorry, if I may just add on, the important thing for all keratotomies is that you have to have 90% depth of your diamond knife. So you have to be sure that your diamond knife is titrated exactly to what you want. That is the important thing. That beyond that, nothing much else. The second thing is I would strongly suggest you look into the papers regarding what we call as lamellating keratotomy, where the incision is made at a 45-degree angle. It heals faster, does not induce problems, and regression is much less.
I think just a small point. I mean, Chitra, I think your question was whether if you have against the rule astigmatism, whether you will use a single arc or a paired arc, because usually we are doing clear corneal temporal phaco or LRCS, and the incisions temporally will be right in the axis where we are making the incision. So initially we are doing single arc nasally, but nowadays we have routinely started doing paired arcs even in these situations, and it's usually at 8 millimeters, and then we are able to make incision temporally, avoiding intersecting with these laser arcuate keratotomies. So I'm able to, most often we are facing against the rule astigmatism in this age group. So I often combine temporal clear corneal incision with a paired arcuate incisions, even in the against the rule astigmatism.
So what Ram is saying is the thing that the intersection should not happen. So you have to move either of the two. So obviously what you would
Maipal, what I'm trying to say is, I make my incisions even when I'm using the LRCS platform. I make the incisions with the diamond knife. So I make laser arcuate keratotomies, don't open them up, but I go temporarily only. But my incision avoids going through the arcuate keratotomy that has been created. And I find that it works well. And at the end of the surgery, I open up these arcuate keratotomies.
That's what you are. And one more thing that I have observed with the recent software is that they are also giving you the toric marking. I think those of you who have used this thing, you can get 2 lines marked on the cornea. And in 2 of our cases, these toric alignment markers and the incision were right on each other. So it kind of opened up. So what I am therefore doing is that I would wish to move the incision slightly off, or what I am doing is that I am doing these markings only at 10% depth. That means that I am leaving from below about 50% and from top about 40%. So there's the intrastromal only 10% of the mark, and you can still see those marks without actually having the problem of intersection. It's not for LRI, but it's for the toric marker that you can now get on the catalyst system.
He's talking about the Cassini upgrade with the
Cassini upgrade with the toric alignment marker. Because they come like this, and when you're going the incision in 2 pieces, that is opened.
Shall we go on with our next team? Great speakers and great thoughts brought up. We could have had more questions. We'll keep it up for later. So Harshul, on to you.
Yes, ma'am. Thank you. So let's move on to the next scenario. The situation is of inadequate capsular support, whether you are going to go for iris clip IOLs or SFILs. So in favor of iris clip will be none other than our ARC chairperson, Dr. Chitra Ramamurthy ma'am, who we all know that by her hard work and dedication towards science, she has taken the ARC to newer heights. And we all know she's a very seasoned and senior player. And up against her is a relatively very young surgeon, Dr. Madan Gopal, but he has a great set of skills and temperament, who is retina and UVI specialist at JB Eye Care Center, Salem. And he'll be speaking for SFIL in this situation. So first over to Dr. Chitra ma'am for her case.
Thank you, Harshul. So, starting off with this debate against my young opponent, I think it's just a totally a no-brainer to even discuss whether there's any other option besides iris clip IOL. I wish I could be dramatic. I wish I could show dramatic videos which would actually help me to present iris clip more favorably. But it is so simple and so factual and so complete. It is so comfortable for all, and honestly is the easiest way out for a comprehensive ophthalmologist. And it is not just for an inadequate capsular bag, but it is for most situations or all situations of secondary aphakia. So iris clip definitely stands supreme. So now, which path do I take? Do I take an easy path or do I take a more rugged, difficult path? See, let's understand, SFIOL seems to have become more and more in the domain of a vitreoretina surgeon. And then the next comes the Yamane lens. And we all know that it is creating a needle track in a soft eye. You might need AC maintainers, you may need trocars, you may not be able to visualize the track, and you may not have centered IOL, you may have to start all over again. And with the glued IOL too, there is a learning curve about how do you do the handshake technique and how do you externalize the haptics and so on and so forth. So in essence, what I'm trying to convey repeatedly is in an iris clip, believe me, there is absolutely no learning curve or a minimal learning curve, because the manipulations are so simple, so relevant to a cataract surgeon. It just appears as if it's just one more step in the cataract surgery. So making it so simple, primary fixation becomes a complete ease, even if you've had a glaring complication or a challenge like an inadequate capsular bag support or more. And further going on, the minimal surgical time, it's all about maximum productivity. I would rather spend if I have a choice of doing something, correcting my mistake or doing a complicated case in 5 minutes, why would I go hankering after an SFIL or M&A? I might do that just to pander to my ego, but then that would be the daily bread, would continue to be iris clip if I'm convinced that it's a safe procedure. Now look at this IOL. It's just an ordinary 8mm IOL and a 5.5mm optic and a constant of 117.2. So if you've had a challenge in your cataract surgery and you have already got an IOL planned for the surgery, you need to just reduce it by 1.5 diopters for the myopia correction which is entailed, and there you are, and you get bang on emmetropia. Now look at this case. All I have to do is, after a aphakia which has got created, after just enlarge the incision, make 2 side ports at 3 o'clock and 9 o'clock, just do a simple vitrectomy, nothing complicated, no challenging instruments. Ensure that there's no vitreous strand. Inject the tricard. Go ahead, do that, and ensure that your vitrectomy is thorough and complete. You could inject pilocarpine and myose the pupil, or else in this kind of a situation where the pupil is already moderately dilated, all you have to do, go in through the side port and just tuck in some iris between the haptics, and the surgery is done. This was a patient who came in with a bag which had got lost during surgery, and that all I had to do was to do just an iris clip lens, and I'm really not going to show you the surgery all over again. It is too damn simple and straightforward a surgery. Now, trying to show you that how this works in all situations. This was a case of a traumatic cataract where both the anterior capsule and the posterior capsule are disorganized. This is a case where the capsular bag support was inadequate, the IOL and the CTR had to be removed, and iris clip IOL seemed to be the answer. This was a situation where a total cataract, lot of phacodonosis. Yes, I veered away from doing a phaco surgery, but then I removed it with vectors and placed in an iris clip lens in no matter of time. And this was again a pediatric cataract wherein All that I had to do is just wash off the cortex and then place, not even remove the bag, and place an iris clip. So essentially, we need to go and look at our results. Is it effective? Is there a quick visual recovery? Are you able to get back to routine? And there are innumerable papers which justify that. Further to this, this was a 5-year-old study which looked at the pre-op visual outcome, post-op first week, and right up to 5 years. And in all, you can see that the visual acuity remained stable throughout. If you look at another study which have compared SFIOL results against iris clip by different authors, in every time point, the iris clip lens seems to have done favorably well. Of course, it is very difficult to assess the visual functional outcome of each of these types because these are lenses which are implanted in situations that there are already some visual comorbidities and of course challenged by a complication. So that could become a challenge in comparing, but we need to look at some basic things. Now, this was an 8-year long-term clinical and visual outcome of iris claw lens compared with SFIOL and compared with glued IOL, and again iris clip lens stood favorably. This is again another study wherein they compared the UBM picture of the retropupillary iris claw lens. It was found to be parallel to the iris plane in every single case, and there was no tilt. Going further, this was again another retrospective analysis, which was again an 8-year study, which again reiterated that iris claw lens is just absolutely right. The issue is there are hardly any complications to look at. It is far away from the cornea, it is away from the angle structures, and again, it is fixated to the mid-peripheral iris, so neither is it challenging the dilatation of the pupil. Intraocular pressure is one very important area which tells us whether there's an inflammation or some irritable eye which is existing, and it was seen that again in this 5-year study that the intraocular pressure remained stable throughout the course of the 5 years. The endothelial cell loss was absolutely nothing which was noticeable. But there are complications of SFIO. Yes, in great hands it does well, but there is a major intraoperative manipulation. There could be a lens there could be a lens dislocation. And again, you're challenged if there's a suprachoroidal hemorrhage, a vitreous hemorrhage, or a retinal detachment. And believe me, there have any number of papers which have shown that lens tilt with SFIO actually occurs in, there has been a huge variability in the haptic position, and it is often not located in the intended ciliary sulcus. But that does not mean, just because I'm going to debate with you, that there are no concerns with iris clip. Yes, you could have rarely disinclavated iris. You could rarely have an oval pupil, or rarely a short term of raised IOP, or maybe an imaginary CME. Probably the only issue of concern is the astigmatism, because a 5.5 millimeter incision is made. Probably it makes sense to have a scleral tunnel, and this is again another paper which says that doing a different incision site to insert the iris clip lens with a scleral tunnel has hardly any amount of astigmatism. Ovalization of pupil is which my opponent may bring out. Now that again is because of a very peripheral enclavation of the iris, and that is just a learning curve. And pupillary dilatation, if at all, is challenged, it's because you need to just enclavate the right volume of iris and ensure that the side ports and the way the iris clip is placed is symmetrical. So essentially, again, if you look at inflammation in these 320 eyes, again, a 5-year follow-up, only 0.9% of these had CME. Again, the central macular thickness, which was measured in these 66 eyes pre-op and post-op, there was no significant difference at 1 year. Of course, there is no established consensus on what is the best choice to treat aphakia with inadequate capsular bag support. I agree. There is no randomized trials, I agree. But then does it not beat logic if you say that the optimal choice of the IOL is something which is straight and simple, which has no challenge in primary implantation, which barely has complication rates? Why, after quoting all these reasons, why would I look at an SFIOL? Why would I look at a Yamanese technique? I might learn these techniques to be a prolific surgeon, but then the best method to my mind is only an iris clip lens for an inadequate capsular bag support or any case of aphakia for that matter. Thank you.
Thank you very much, ma'am. But you said you didn't want to be dramatic. That was very nice, ma'am. So Dr. Madan Gopalan, ma'am has shown easiest path, no, for these cases. Why do you want to walk the difficult path? Can you unmute yourself?
Yeah.
Yes.
I will just share my slide now. Okay,
Yeah.
and hope my slides are visible. Yeah. So, a very good afternoon, everyone. I thank the ARC and its chairman for this wonderful opportunity. After that, a wonderful talk by ma'am herself, enumerating the benefits of iris claw lenses, I understand that my task is a little tough. Anyway, I'll speak in favor of SFIOLs. So the first question that comes to mind, and ma'am has been repeatedly showing a lot of videos, an iris claw lens is okay for this eye. But what do we do here? An iris itself is not present. These eyes have no capsular support, yes, but cases of complicated cataract surgery or ocular trauma often present themselves where the iris itself is damaged. Many a time I've referred these cases with retained nucleus or retained IOL where the iris has been damaged during primary surgery. Placing an iris claw lens here is very difficult, if not impossible. Even if the condition is very favorable, even if we have the best surgeon operating, the eye on the left is what you would end up with. Worst case scenarios can look like the eye on the right. What I'm trying to say is that iris claw surgery, although shorter in duration, although simple, it offers very, very little margin for error. As long as enclavation is not done, things are okay. But once you enclave, you better get it right at the first instance. If you have to disenclave and do it again, things become really messy. This is a picture. I just took it 2 days ago after I was given this topic. I took it 2 days ago in my OPD. A very well placed iris claw lens, I must say. But as a VR surgeon who did the retinal detachment surgery about 2 days ago, I can tell you two stories looking at this picture. One, the patient has had a retinal detachment after primary iris claw placement. Why? I leave it to you to guess. Two, this is the maximum that this pupil will dilate. This is the maximum that this pupil will dilate. So dealing with a macular pathology or a pathology in the mid-periphery is relatively easy, yes, but dealing with a peripheral problem is really difficult, especially after doing a retinal detachment surgery. If I want to check the periphery, if I want to make sure everything is fine, if I want to make sure my break is flat, it is a little difficult. So that's why an SFIOL is preferable. There are various methods and techniques. This is an article that goes into SFIOLs in detail, but for this very short talk, let me just mention that broadly an SFIOL can be looked at as a sutured or a non-sutured one. The 2-point fixation using a 9-O-proline is the simplest, all of us know. But you see, this kind of creates a pivot on whose axis the IOL can rotate. As ma'am was mentioning, IOL rotation and tilt is possible. That's because you're having only 2 points of fixation. To eliminate this, we moved on to another technique of 4-point fixation. It's a little more complicated, but again, the stability is a little better. You can use scleral flaps or you can use Hoffman pockets. Now that was about suture SFIOLs, and I'm sure all of you will agree that we are now doing more of sutureless SFIOLs. This requires the use of 3-piece IOLs that have larger overall diameter and proline haptics that are more forgiving of haptic manipulation. Gebor started it off with this tunnel and tuck method. Agarwal has popularized the flap and glue technique. Anyway, whatever choice is yours, it's fine. Another recent modification about the Yamane technique, he uses a cautery to create flanges. But my personal favorite remains the simple XNet technique developed by Dr. Prabhu of Arvind Eye Hospital. It's a completely extraocular procedure. The argument, as ma'am said, the argument against an SFIOL has always been that it is difficult to perform, it requires a lot of instruments. Well, this technique simplifies the entire process. The exteriorization of haptics is performed using a 26-gauge needle or the XNet kit. And the entire process of haptic docking happens outside the eye. As you can see here, it happens outside the eye. So complex intraocular maneuvers that are prone to, create problems, they are eliminated. They're completely eliminated. It's a completely extraocular procedure. So the first haptic is exteriorized. The second one is also exteriorized in a similar manner. Readily available instruments, just have to dock it and pull it out through the other side at 3 o'clock. Once both haptics are exteriorized, you see that here I'm using no flaps and using no glue. The haptic can be tucked into the preformed scleral tunnel by using the intraocular forceps or the McPherson forceps that is readily available. Now you see in this particular eye, the iris is damaged. The pupil is not very regular, but still an SFIOL can be placed with very good results. Now we have innovations like the CM-T-Flex SFIOL by Dr. Nivian of Chennai that is really creating waves. This lens has simplified things even further as far as fixation of an intraocular lens to the sclera is concerned. It's foldable, it's got a T-shaped haptic. All it needs is a simple grasp, pull, and release technique. We avoid the complex haptic manipulation that those maneuvers took time, and those maneuvers are often cited when speaking against esophageal. So these kind of esophageals, they eliminate the problem altogether. We see that it's acrylic material, pliable. So a 23 gauge sclerostomy is all that's required to gently pull the haptic out, the T-shaped haptic out, and leave it. So since it's made of acrylic, it simply springs open and anchors itself to the sclera. The same is repeated for the other side. We use a handshake maneuver. The second haptic is pulled out by holding the center of the haptic in a firm manner. Gently pull out the haptic from the other side at 9 o'clock meridian. Once it's out of the eye, we release it and we see that the T-shape springs back to its natural position and anchors itself to the sclera. And that's about it. It's as simple as an iris claw lens that man has been showing. So in summary, what's often quoted against an esophageal is the duration of surgery and instrumentation required. But as I explained, with present techniques, these no longer hold ground. On the other hand, there are many advantages. Most important among them is that a vital tissue like the iris is not disturbed unnecessarily. Dilation is good, inflammation is not prominent. IOL occupies the same position as would an in the back lens. Removing or repositioning an esophageal for whatever reason, be it during primary surgery or later on, is relatively much easier. As I said, iris claw lens offers very, very little margin for error. Whereas an iris claw lens would require less training, less surgical time, and the patient finds immediate post-op period more comfortable, the advantages of placing an esophageal begin to show up after the initial few weeks. Of course, it's important to start well. It's more important to finish well. As a VR surgeon who uses all types of these lenses, I have no hesitation in saying that esophageals are better in the long run. Thank you for the opportunity and your time.
Thank you very much, Dr. Madan Gopalan.
Yeah. Very well. Actually,
yes.
Harshul, we are really running short of.
Yes, ma'am.
Sorry, I'm going to ask Madan Gopal just one question, and I'll go on to the next speaker. If there is a scarred conjunctiva from previous surgery, Dr. Madan Gopal, how would you plan your haptic positioning?
Depends on where the scar is, ma'am. Usually, the scar would be superiorly. Hello?
Yeah.
I'm audible?
If it is
the scar that you talk about is going to be superior, ma'am, because somebody is going to have you open the superior conjunctiva. I have no hesitation in using that place for a tunnel again and putting the haptics temporal and nasal.
Okay, right. Thank you very much. That was a great talk of yours, and we shall go on, stay with us till the end. We shall now go on to our next team, which is going to be led by Dr. Nitin Balakrishnan, who is a medical director and heads the cataract and refractive services at Sai Deepa Eye Clinic and Crystal Vision Center, who is going to debate that niche practice is the way to go in cataract surgery. And he would be most effectively countered by Dr. Haripriya Arvind, who is the Chief of Intraocular and Cataract Services at Arvind Eye Care Systems of Chennai, who is going to tell us that cataract surgery is all about volumes. So on to you, Dr. Nitin. Can you share your presentation? Can you unmute yourself, Dr. Nitin?
Okay, are my slides visible?
Yeah, yes.
Yeah, thank you, Chitra. Thank you, ARC and AIOS for having me, giving me this opportunity. Is niche practice the way to go in cataract surgery? Now, let's start off with what is niche. Niche, as per the Webster's dictionary, denotes products or services that appeal to a small, specialized section of the population. So does one have to be a lone wolf as opposed to a part of a pack? Well, there are definite benefits of niche practice. All patients appreciate that personalized private practice when given to them. And the quality results for every patient is very, very important because, as you all know, every eye deserves the best. And in this era, customization for every case is very, very important. In the era where cars are customized, where the dresses are customized, including shoes are customized, why not customization in cataract surgery? And this is possible by our various diagnostic methods, right from the corneal topographer to the optical surface evaluation. We all know toric IOLs are here to stay, but are routine tests just sufficient to get good results with toric IOLs? As previous speakers have spoken, Additional tests for optimal outcomes like the Varion image-guided system, topography, aberrometry are very, very important for giving good results. The Varion captures the image, calculates the toricity and the corneal power, and helps us to plan a customized toric planning for each and every patient, which includes the incision site, as well as the toric positioning and the right toric IOL, which can then get transferred to the MDO on the microscope and give you a good overlay and a guide to position your toric IOL. The corneal topographer helps in differentiating between a regularly irregular cornea and a irregularly irregular cornea, where normally a toric IOL would not give good results. Again, an aberrometer helps to differentiate between corneal astigmatism and lenticular astigmatism. At the same time, in cases of multifocal IOLs, it helps to quantify the higher order aberrations. And we all know that aberrations more than 0.50 microns are unfavorable for multifocal IOLs. The eye trace examination helps to calculate the angles of the eye, that is the angle alpha and the angle kappa. And this is very important, as proved by peer-reviewed literature, that any angle alpha more than 0.5 again gives poor results in cases of multifocal IOL. Macular OCT is very, very important because, as we all know, there are quite a few macular pre-existing conditions which would give unfavorable results, which are normally missed by routine ophthalmoscopy, as well as both direct and indirect ophthalmoscopy. The evaluation of the ocular surface, one doesn't need to give more stress on this, because in the end, we find that most of the unhappy patients are because of a poor ocular surface. And this, therefore, can a pre-operative evaluation and treatment of poor ocular surfaces is therefore very good, is very indicated in cases where we're doing a premium IOL. Use of online calculators for determining one's own surgically induced astigmatism is very, very important. And this can be done either by the Hills surgically induced astigmatism calculator or by the Varion imaging system, where it calculates the surgically induced astigmatism for different incision sizes and different locations, and then helps to recalculate the surgically induced astigmatism for each and every surgeon in the planning station itself. LRIs with the Varion image guidance system are also very, very useful in cases of low diopter corneal astigmatism, which are not usually cases for toric IOL. The use of the website online calculators for post-LASIK cases again gives you more perfect results as opposed to the general non-utilization of these online resources. So basically, what one needs to see is the change of the ideology. One needs to incorporate the ideology of the niche practice to the volume practice. Volume practice should not be just numbers, because numbers, each patient cannot be considered as a number. It is important that one goes into an ideology where one is ready to earn less and get more satisfaction by giving a perfect result to the patient and having every patient as a 20/20 happy patient. Restricting volume practice only for cases that need urgent care is, I think, the most important tenet of today's practice. We know that in spite of 73 years of independence, in 2021, we still have the social divide. So what one needs is probably incorporating all the tenets of the niche practice into volume practice and not consider volume only for the sake of volume and numbers. Thank you.
Thank you, Dr. Nitin. That was a wonderful talk. Shall we hear from you, Dr. Haripriya?
Sure. Thank you very much for the opportunity. Yeah, so my topic is on cataract surgery is all about volumes. So I think we again go back to the automobile example. Of course, we know that the BMW and Benz and the Audis do have much higher safety features, but what percentage of the number of cars which are sold belong to this category? So in 2019, of the 3 million cars sold, less than 1%, which is about 35,000 cars, belong to this category. So it is not something which everyone can afford. Moving on to cataract surgery, Again, for India, we did about 7.4 million cataract surgeries in the year 2019, about 75% of that volume last year due to COVID. As we know, most of these, I think more than 4 million procedures are done through the DBCS NPCB grant from the government aided CAM surgeries. So while we do have the option of premium surgery packages of over $1 lakh, we do know that femtosecond accounts for about less than 1% of our cataract surgeries today. So if you want more people in India to see, so we would have to think of high volume practice. Moving on to affordability. So the GDP in India, the per capita GDP in India is about $2,000. And in the UK, it's about $40,000. So we cannot give the exact options which is available in the US and the UK to our patients. We have to give it for those who can afford it. But only having that option for all patients is not going to help solve the problem of blindness. So in spite of having a much higher GDP in the UK and the problem of blindness not being very high, this is a recent report which they have come up with. It's a 50-page detailed document which the UK has come about, where they're trying to plan to increase the number of cataract operations from 2015 to about 2035 to by about 50%. And they want to see how can you make the procedures and the different practices more efficient, because they also realize it's not going to be easy to have a commensurate increase in the number of ophthalmologists or the different eye care personnel. And also in terms of the financials, just by increasing the cataract surgery list from 5 per surgeon to about 8 per surgeon, they show that the profit per case actually in fact doubles. So this actually volume does also make your practice more financially viable as well. Again, so the cataract surgical rate in India, so how are we doing here? In 1981, the CSR in India was about 700. So we have come a long way. I think India has been one of the global leaders in terms of improving the cataract surgical rate. It's about 6,000 in 2012, based on the census. We're much ahead of countries like China, which has a huge public health problem because of cataract blindness with a CSR of about 1,000. But are we doing enough? So India, with a population over 60 being about 9% in 2015, it's probably going to double to about 19% in 2050. And in terms of numbers, that means almost triple the numbers. So we'd probably increase from 116 million in 2015 to about 330 million in 2050. So if we have more patients over the age of 60, this means having more incidence of cataract and other eye diseases, illness in the future. So are we ready and are we geared up for that? So considering both the affordability and this huge burden of blindness, I think the need of the hour is to have a large volume, high quality eye care setups. The goal here is to strengthen the eye care delivery system by a comprehensive, volume optimized, protocol based, standardized, safe, cost effective, sustainable, high quality and equitable model. So I think each of these phases are important. And this is where we'll be able to give our patients and be able to address the issue of cataract blindness in the country. And we also have the benefits of economics of scale by reducing the cost both to the patient and to the provider. Again, needless to say, if you want to do high volume, one has to have a quality assurance process in place. I think they both go together. It's impossible to do high volume with low quality and compromised care, because that will probably only bring in more problems for you. It's also important to standardize different tasks, including patient communication. So if it's performed at the right time and the correct manner every time, this will actually systematically minimize errors, reduce costs, and build both the patient confidence and patient satisfaction. So in terms of doing more volume, so we keep hearing that increasing surgical volume would increase your complication rates, make your outcomes worse. But actually the reverse is true. So this is published in ophthalmology last year from the National Swedish Registry, and in their series of surgeries which were done between 2007 and 2016. So when they began in 2007, when the surgeons did about 300 surgeries per surgeon, their complication rates were much higher. It was about 1.5%. And as the number of surgeries per surgeon increased over the next decade, to about 450 surgeries per surgeon, the complication rates actually halved. So this actually is evident. So I think once one does do more volume, the complication rates do drop, because like I mentioned earlier, if you're going to do high volume surgery, you need to have be able to give consistent, good quality outcomes. What about endophthalmitis? So this again is an interesting paper from Taiwan, which looks at 494 hospitals, and they looked at a series of about 1 lakh or more patients. And they reported that the patients who receive cataract surgery at low volume hospitals or by low volume surgeons have significantly higher risk of postoperative endophthalmitis than at high volume hospitals or high volume surgeons. Again, these are not reported by low volume hospitals or surgeons because it takes a much longer period to come across those number of patients who have postoperative endophthalmitis. We have seen the same within Aravind as well. In our recent publications, both in the series with 600,000 surgeries and the 2 million surgeries, where we try to compare the two groups with and without intracameral moxifloxacin, the postoperative endophthalmitis rate, once we had intracameral antibiotic, was about 2 per 10,000 surgeries, which is significantly lower than the American Academy of Ophthalmology's IRIS registry's post-op endophthalmitis rate of 0.04%, which is published again last year in ophthalmology. So your high volume also does give you various lessons which will help you take the right decisions and right direction, both for your own hospital and for other institutions to share as well. And by doing more surgeries, and if you're also going to have your combination of free and subsidized, this slide shows the income and expenditure graph over the last 4 decades at Aravind. And you can both do good and do well. So though only 53% of our patients are paying patients, we find that this model could be both financially sustainable and you could have a self-sustaining model in place. So to sum up, a niche practice, the motivation to either have a niche practice or a large volume practice would be based on the individual ophthalmologist. If one wants to cater to the class clientele, have patients seek the individual doctor, and if one intends to charge more procedure, this is good. A large volume practice is based on considering the burden of blindness and affordability. And they also have a clinical team which works together. The patient would come for the institution and not the individual surgeon. And there could also be the advantage of having lower charge per procedure, but the net income could be higher. So the net income is higher. So like Dr. Nitin mentioned, institutions can go ahead and invest in more expensive, sophisticated equipment. So more patients get the benefit of these high-end equipments as well. So in conclusion, I think we all know that in 2020, about 75% of our usual cataract surgery volume was performed compared to the pre-COVID era. And because of that, all of us saw an increased issue with blindness. We saw more patients who had more advanced eye disease and advanced cataracts. And I think ophthalmologists are the blessed few who have the unique skill to reduce blindness, and just by doing our daily routine work. So I think it is our responsibility and right to use that skill on a large number of patients and help more people see. Thank you.
Thank you very much, Dr. Haripriya. Both the talks are very good. So I have just one question to you, and I would ask the other speakers to start sharing their screen. The next one. How do you counter patient migration, which could occur in some of the dissatisfied patient in a high volume practice? And number two, the main question which I have is, sometimes we need to get some extra instrumentation like visual evoke potential and those kind of instruments which rarely get used. So how do you justify the cost recovery from some of these rarer instruments for a larger setup?
Yeah, so I think regarding if you have cross migration of patients to another setup, I think that is not a major issue. At least the patient is seeking care, and if they get good care, it's perfectly fine. The bigger issue would be if they don't seek care, if they don't have a place, if they don't have access to eye care, that would probably be the bigger issue to me. If you have the right system, standardized protocols, good quality, there is a high chance that the patients would come back to you for your second eye or for their other ocular needs as well. Regarding the other point of having high-end equipments or equipments which are where we use them far few, I think that is where again the scale plays a huge role. So because of the scale, we find that investing in these high-end equipment does make sense because you will have enough number of patients over a period of time, maybe not as soon as you buy them, but over a period of time, based on how you use it and how the protocols, you'll find that you're actually able to use them when you have a large volume practice.
Thank you very much. Thanks a lot. Harshul, can you introduce
Yes.
the next?
Yes, ma'am. So the next topic is very controversial. A patient with angle closure, glaucoma, raised IOP, and significant cataract presents to you. So what should be the approach? And debating on this are two stalwarts of glaucoma, Dr. R. Venkatesh, who we all know is the head of glaucoma services at Arvind Eye Care System, Pondicherry, has innumerable awards and innovation to his credit. He believes in doing combined phacotrabeculectomy in this situation. And opposite to him is Dr. Ronnie George. We all know he is a deputy director and senior glaucoma consultant at Shankar Netralaya, Chennai. So over to you, Dr. Venkatesh. Can you unmute yourself, please? Please unmute, Dr. Venkatesh. No, your screen was, yes. Please share your screen again.
I'm going to reshare, yeah.
Yes, sir.
Yeah, now you are heard well.
Sri Ram Mohan Anna. Okay. So that's very important. The three things, you're going to take care of three things here: raised IOP, angle closure, and significant cataract. So that's why I'm going to say why phacotrab, at least in our practice back at Aravind. Because you're going to prevent angle closure, you're going to control the intraocular pressure, which is very important post-operatively. And of course, depending on the optic nerve damage, if it's already a compromised nerve, you want to prevent further damage. So that is why we are trying to see whether we can knock with one stone. So definitely there are a lot of these advantages to the patient, but we also have to keep in mind the long-term outcomes and complications, because for a patient, it's a single visit to the OR, a single procedure. It restores vision promptly. There is a significant reduction in the cost, which is well proven in several studies. And of course, it reduces the carbon footprint. It reduces the anesthesia-related complications. And also, post-operatively, if they can get a good control, they are off anti-glaucoma medication, which is again going to save money and the conjunctiva to the patient. For the surgeon, again, it's little cumbersome, but again, a single procedure. Definitely decrease glaucoma medications post-operative for the patients. You don't have to see them often if you just do a cataract surgery. And also good early intraocular pressure control, which helps you to save already the compromised nerve. And of course, now you have other surgical options also. Once you have done this is failed, then you can think of other options for these patients. So why phaco alone is not sufficient? There is a lot of evidence for and against, but definitely IOP spike following cataract surgery is not very good. The fluctuations is not very good for these patients because they have a sensitive optic nerve, which can be kind of damaged because of all these fluctuations. And of course, you put them on steroids for a longer period, they may have a steroid response. And post-operative medications, you may have to use, if the pressure is high, you may have to use anti-glaucoma medications with these post-operative medications. So what we found was just doing a cataract surgery in an angle closure, sometimes the amount of angle opening is not as you expect, especially if they have already a compromised angle in the form of synechase. And many of the patients have a modest IOP control following cataract surgery. And of course, you have to use glaucoma medications after cataract, which is again going to compromise the ocular surface. In a future trabeculectomy, the failure rate is going to be high. So I would say these are the relative disadvantages which my good friend is going to debate, Ronnie, because the combined surgery may take longer. There is a chance for increased intra and post-operative complications. And of course, you need to do more intensive post-operative care, which is very common in any glaucoma surgery when you do. So I would say all these are relative. Why? There are a lot of evidences, but mostly the kind of landmark evidences is from my good friend Clement Tam, where he has done this randomized trial either for a controlled, medically controlled chronic angle closure patients with cataract or patients who had uncontrolled chronic angle closure. And all these randomized studies proved that the combined phaco-trabectedin was marginally better and effective in controlling the intraocular pressure than phaco alone. But the problem was the postoperative complication, I think, which is the important part, and I'm sure we are all concerned about. If you see intraoperative complications in both the studies, they were not much, even slightly more in the phaco group than even in the combined group, when you talk about PCR and zonular dialysis and other complications. But the postoperative complications are more. Why? Because most of these trials which were done are earlier, way back in 2008 and 9, before 2010, when we didn't know how to do even a safe trabeculectomy. Even though trabeculectomy is 60, 70 years old, the learning on trabeculectomy is better and better in the coming years, over the years. And in the recent past, of course, after the safe trabeculectomy system, we have learned a lot how to do a good safe trab, as also a safe combined in some of these angle closure patients. So let's take this report, which they published in 2020, which is the 5-year results of their previous trial, where they're talking about the complications in the two groups after 5 years after the initial study. If you see that most of these complications are related to anterior chamber reformation and all those conservative measures for conjunctival wound leak, if you see those top three. And if you do a safe system, I'm sure you can remove all those complications. And definitely hyphemas. 4 of the patients had marginal hyphemas which resolved over a period of time. I'm sure many of them have, and they disappear because angle closure tend to bleed and then they resolve. And if you take PCO, I think PCO is not a big deal. Now, because of the intraocular lenses, square edge and all that, even in a PMMA, we don't get much PCO. Let's forget the PCO. And if you take, again, blebitis, which is quite uncommon now. We have proven that, again, with intracameral MOXIE, there is a 4-fold reduction, not only in endophthalmitis, but also in blebitis and glaucoma patients. So let's remove that also and see what's the complication. Phaco group, it's 4, and in the combined group, it's 9. So this is what will happen over a period of some years in these patients. So what is more important is they also came up to say that the phaco group, 10 patients had trabeculectomy after that. And in the combined group, no patients had any other surgery. So this is the important point. In that trabeculectomy, again, you will have complications, either bleb leaks or bleb overfiltering blebs or conjunctival suturing and things like that. But if you're going to do again a safe trabeculectomy, I'm sure all those complications are going to be less. So that's the very important, or the crux of this, many of the evidence which are available, at least at this point of time. But in our experience, we have found that now a phaco trabeculectomy is the way to go when you have high pressures, angle closures, and significant cataracts. But of course, we are looking at more evidence, and we are also working on it, because some of these trials, there are several surgeons who have done, the results may be different. Some, they don't even classify between whether it's early or advanced. Depending upon damage also, we have to decide. And of course, we have to keep in mind how to reduce some of these complications with better and skillful surgery. Thank you.
Thank you very much, Dr. Venkatesh. Now let's hear it from Dr. Roni.
Yeah, are my slides visible?
Yes, we can see that.
Thank you, Harshul, and thank you, Dr. Chitra and ARC, for the invitation. So my good friend Venkatesh has been trying to tell you that we need to do a phaco trab each time. Logically, why does only cataract surgery help? By completely removing the pupillary block and reducing the lens volume, you create space. It also reduces the anterior positioning of the ciliary processes in eyes with primary angle closure glaucoma. And you have this paper from Tanuj Dada, which shows you good UBM findings of how the angle has widely opened. All UBM parameters and anterior chamber depth change dramatically after cataract surgery alone. In fact, even before you develop a cataract, if you look at just this major review from Survey on clear lens extraction in eyes with primary angle closure glaucoma, and clear lenses are less thick than cataractous lenses, what you find over here is in the 5 studies that I have marked out over here with medically uncontrolled primary angle closure glaucoma, all of them had a between 48 and 93% reduction in intraocular pressure. Number of medications required also came down dramatically. The highest level of evidence is our meta-analysis. And I'm going to share with you this global meta-analysis, which was based on 7 randomized controlled trials. I want you to pay attention only to the highlighted studies. And these are all studies where the intraocular pressures were uncontrolled. And in each of these studies, the intraocular pressure reduced by between 5 to 17 millimeters of mercury. If you look at the medication used for the studies where it was reported, medication came down from 1.2 to 0.1 or 3 to 0.65. And in fact, my friend Venkatesh has been talking about Sinecare. And if you look at this study, which in this study, where they did cataract surgery alone, there was an average of 218 degrees of peripheral anterior Sinecare. So even in eyes with significant Sinecare closure, cataract surgery alone did fairly well to reduce intraocular pressures. What about Indian eyes? Because that would be the other argument. What about Indian eyes? And we have this paper from PGI Chandigarh, and you can see that in medically uncontrolled angle closure glaucoma, we got intraocular pressures down by about 6 millimeters of mercury. The number of medications required came down from 3.7 to 2.25 in the medically uncontrolled group. And if you look at those IOPs, in those with an IOP of more than 31, you had an almost 20 millimeter reduction in intraocular pressure, and those with IOPs of 22 to 30 on an average, an 8 to 9 millimeter intraocular pressure reduction. Going back to this paper which Tanuj Dada had published, in their 46 patients, the mean intraocular pressure was 25 millimeters of mercury on maximum glaucoma medications. At 12 weeks, the intraocular pressure reduced by 10 millimeters of mercury. The number of medications reduced from an average of 2.5 to 0.4, and hardly 2 of them required trabeculectomy. What about this study? And this basically looks at what intraocular pressure, what happens to IOP reduction after just cataract surgery normalized. So we've been talking about glaucoma, but what about normalized? And you can see that even in normalized, any sort of small incision cataract surgery did reduce IOP. You look a little more closely at the paper and you'll notice that it's my good friend Venkatesh who's actually published this information, and now he's trying to persuade us to do unnecessary glaucoma surgery in some of our glaucoma patients. He brushed over these complications, saying these are all nothing much. But these are things like a wound leak, you need to take back to theater, you may need to put a patch graft, you may need to give autologous blood, you have an encysted bleb. This is all increased chair time that happens in the hospital, increased follow-ups that these patients have to do. And these are anyway things that we know how to deal with. But what about things like this? Chronic hypotony, visually threatening, blebitis, or a malignant glaucoma. And a malignant glaucoma, this is from the CGIT study where it was all open angle glaucoma. In angle closure, we know that malignant glaucoma is much commoner in these eyes. He also said that the risk of endophthalmitis is not very high. If you look at the paper that he showed, it was 2 out of 62, which is actually more than the 1.5% that I am showing over here. And this is a 5-year risk of endophthalmitis. It's a long-term risk of endophthalmitis, which is more of an issue than the short-term risk of endophthalmitis. The short-term, you might get away with moxifloxacin, but in the long-term, you will not. So in my opinion, cataract surgery in eyes with PSCG and uncontrolled IOP is the way to go because it's anatomically logical. It helps even in eyes with significant PAS, and there's good evidence that it reduces IOP in normal eyes with PACS, PAC, or medically controlled PSCG. Plus, perhaps most important for all glaucoma surgeons, you can sleep peacefully at night knowing that the patient is not going to have a flat AC the next day. Thank you very much.
Thank you, Dr. Roni. So before we move on to the expert panel for their comments, I'd like to ask Dr. Venkatesh, do you prefer single site or 2-site phacotrap? And second is, what if you have a PCR and vitreous loss during phaco? Would you continue with phacotrap or you'll abandon the trap part?
Yeah, for the first question, I prefer to do a twin site and an angle closure. For a simple reason, I'm comfortable doing a phaco temporarily in an angle wherever it's a difficult cataract. In an open angle, I do a single site, because the chamber is deep and it's very easy to do some of these cases superiorly also. The second question, depending upon how the PCR is and how the need for vitrectomy, I would decide. If it is more superior, if it is near the ostium, where if I believe that the vitreous can move in and block, I may even not continue with the trabeculectomy or making an ostium. I would just close the flap, which is already constructed. But if it is more central, the vitrectomy is fine. I have a lens nicely placed in the sulcus or in the back, then I would go ahead and do a trabeculectomy. So again, angle closures, I would reconsider. I would just close the wound if needed, but in an open angle, I would still continue.
Yes. I would want our next speaker to start sharing, but getting out of this debate, I want a true answer for this question. A patient with an advanced glaucoma where the IOP is not getting controlled, don't you think doing a combined surgery makes sense than rather doing a cataract alone and exposing the eye to IOP fluctuations post-op and that further endangering the nerve? Question number 2, in a very small eye, early lens changes, patient not doing well with the medications given, needs a trabeculectomy surgery, would you not decide to remove the cataract also at that time, rather than have a post-operative shallow anterior chamber and have a difficult cataract surgery done later? I just want one-line answers for each. Yes and no.
Ronnie.
Ronnie.
Okay. Yeah, the first question, very bad damage, uncontrolled IOP. Definitely better to go with a combined surgery than with a cataract alone. If there's not very bad damage, do the cataract alone and see what happens. Now, a very small eye, not doing too well, very early cataract, you can definitely do a combined surgery. Or if you want to be a little safe, you can tell them you can do a stage surgery, do the cataract first, wait 3 months and do the glaucoma surgery after that. It gives you a little more space to play around with post-op.
Even with uncontrolled IOP?
Depends on the amount of damage.
Thank you very much. There could be a lot of questions asked, which are two great speakers, but paucity of time. We go on to our next team. Do stay on with us. Our next team includes Dr. J.K. Reddy versus Dr. Revati. Dr. J.K. Reddy is going to be talking on cataract surgery alone, DSEC can follow, if necessary, versus combined phaco with DSEC by Dr. Revati. Dr. J.K. Reddy is the director of Shankara Eye Care Solutions at Coimbatore, heading the cataract, cornea, and refractive department, a great surgeon of versatile skill sets. And Dr. Revati is the chief of cornea and refractive surgeries at Arvind Eye Care Systems, Coimbatore, a leading figure with significant contributions in many clinical trials and many publications to our attributes. Look forward to both of you. On to you, Dr. J.K. Reddy.
Yeah, good afternoon. And I thank Dr. Chitra Ramurthy for giving me this opportunity and the ARC team. And coming to my case, this is a 60 years old patient, corneal thickness 600 microns and endothelial cell count 1000 cells per millimeter square millimeter, and the cataract grade 2. What to do? This is very simple, straightforward. I don't see any problem. This is just a phaco with IOL and topical. And shall I warn the patient? That's the question. You will land up in problem. There is no need to warn. This is a fairly assured case of getting good results. So we just inform the patient. We don't warn him that you don't get vision or you land up in trouble. We just inform them that your cornea is a bit weak and in future you may need, maybe after 4 or 5 years down the line, you may need a transplant. Not a transplant exactly. What is the points in favorable of my decision? One thing is it's a clear cornea. They said it's a clear cornea and cells are quite good. 1000 cells is a beautiful. Most of the times when we operate in post keratoplastic cases, the cell count will be somewhere around 600, 700. We get excellent results. So that's based on that. 1000 cells are very good. And grade 2 cataract, another very favorable one. This is not a very difficult one to get out without endothelial cell damage. And added to that, we have in the armamentarium very good viscoelastics now available, freely available from both from Indian companies and from across the world. And we have excellent irrigating solutions with a proven protection for the cornea, which will protect the cornea. The maximum endothelial cell damage will be around 7%, at the most 5 to 6%, and 7% will knock off around 70 cells, and it comes to 900. That's good enough for another 10 years. And added to that, we have excellent machines available right now. Looking at 10 years back, where the literature, all published data is there. And these machines helps us in reducing further the endothelial cell count to barely around 3% to 2%. And what is the against? The against is the old dictum that given in the book. 600 microns means decompensated cornea. It's a myth. It's a myth written in the books. A 600 microns cornea, you should go with a endothelial graft given. It's so many cases of LASIK we are doing with a very good endothelial cell count, 600 microns cornea. 600 micron cornea is just a variation outside the Gaussian standard 550 microns. That's all. It's nothing to do with the decompensated cornea. Unless you have a prior corneal thickness of 500, now becoming 600, then you can think decompensated. Otherwise, a first reading 600 microns is no way to say it's a decompensated cornea. And endothelial cell count saying 1,000 cells are very low. That's not a valid argument. The cells, we have excellent machines, specular microscopes, we have excellent machines, which are very good in image, getting a image and analysis. But what they miss is, you look at the picture with your eye, you can easily differentiate within 5 seconds, which is good, which is bad. But the same thing for doing these missions impossible. They are very good analysis, very good imaging machines, but they don't have intelligence. They cannot diagnose a abnormal cornea from the normal cornea. They give a lot of parameters which you need to study. So it's like a auto analysis is like a autopilot for a car. If you believe, you will definitely you'll end up in an accident. So you just, what I say is just look at the image. For example, this particular cornea, it shows 2000 counts, but you see so much damaged area. So don't believe by auto analysis from specular microscope on counts and volumes and the numbers. Just have a look yourself personally at the image and come to a decision. If science proves something is wrong, then it's the time to change it. So with our experience, we are seeing very good results. There is no point even to think about a preventive thing by doing a DSEC or something like that. We have to just straight away go, and we have to change what is given in the literature, as this is not a safe technique. Thank you very much.
Thank you very much, Dr. V.K. Reddy. That was a convincing debate. On to you, Dr. Revati. Could you share your screen?
Yeah. I will stop sharing.
Can you see the slides?
No.
No, I have to stop sharing.
You stop sharing. Dr. Revati, just click on the share screen button on the Zoom window.
Can you see now?
No, you will have to click on the share screen button on the Zoom window where the Zoom application is. The green button, 6 o'clock bottom.
Yeah. Yeah, I clicked it.
The pop-up, when the pop-up comes, just click on the share again. On the pop-up, just click on the blue button which says share.
Yeah. Can you?
No.
Are you on Mac, Dr. Revati?
No.
Okay.
This is only.
Fine.
Yeah, you stopped it, I guess. Just start again.
Start again. Not able to share?
1 second. Can you?
Yes.
Yes.
Perfect.
Okay. Thank you. So thank you for calling me this session, for this session. And Dr. Reddy has very clearly, nicely, he has put that why we have to go for only the cataract surgery. But for me, this information given about this case scenario, they are not adequate. For the first reason, it's mentioned as only 1,000 cells and 600 micron, as Dr. Reddy put it. 600 micron is, it can be even normal, even in a patient who comes for refractive surgery, sometimes we come across. But why 1,000 cells? What is the pathology behind? That's what I would look into. Is it a degenerative or a dystrophic condition like Gateta or pseudoexfoliation, or is it a post-trauma? So what is the reason for that poor endothelial cells? And then also I'll, of course, the patient should have come only for visual symptoms. That's why we are considering cataract surgery. But whether this is not enough. For me, I look at, as Dr. Reddy already beautifully put, the number alone is not enough. In the specular picture, we have to look at the morphology and how much damage has occurred for the cell morphology. And in addition, another clue is whether there is a diurnal variation in vision, whether there is early morning blurring. So you can calculate something like, even some of them can show even 6/6. But if you talk to the patient, they may say that early morning blurring that show that that's a warning that this cornea, though it looks clear to you at the time of examination, it's not clear always. And also the lifestyle demand, whether the patient will be ready for two-step surgery and how their cornea is going to be post-operatively, whether they are ready to accept it and wait for another surgery. So even just because it is 60 year, we cannot say, as Namrata put it, many of us in that category, and of course our lifestyle cannot, we cannot, if there is a choice, we will go for a one-step surgery, definitely. And points to ponder when we are, other points also, that what the patient wants, as I said, a good visual recovery as soon as possible. So what we are going to do by doing cataract surgery alone, if this cornea is, for example, a Fuchs cornea. So we may end up with whatever precaution you take, we may end up with a cornea like this. We may not be so much scared about this, but the patient will not be very happy, but we can reassure them. It may recover in due time, and but at the same time, we have to tell them later they may need another surgery. Or we may end up like this also, even with all due precaution. We may end up like this, and then a cornea like this, and then of course it's a really very embarrassing situation. And in addition, we are talking about the visual symptoms and how much was of that is contributed by the diseased endothelial desmoid membrane complex. The negative asphericity by the severe Fuchs itself can cause some visual disturbances. Of course, that they are not going to be addressed only by the cataract surgery alone. And also we have to discuss about the logistical problem of a patient as well as the attender, whether they will be able to bring the patient again for another surgery. All these things we have to discuss with them, and then allow them to make a decision. And why are we so much concerned about doing a bilateral, I mean, at the same time, a combined surgery? One is we can think about safety, but this is more so in case of open globe PK surgeries. But nowadays, the EK surgeries are closed globe surgeries. It's as easy as just inserting an IOL just behind the iris. You are going to put it just beneath the cornea and put it in position, and just we are going to leave it. It's as simple as that. And coming to the post-op complications, of course, we have to really we have to look into it. One of the main complication I'll be worried about a combined surgery is the CME. CME incidence is definitely high in a phaco with an EK triple compared to either surgery alone. But since we are aware of it, and we'll be looking for it in the immediate post-op period with sophisticated instruments, and we can, even if the like immediately we can find out, and then we can go for preventive measures with very good results also. So the long-term problem about graft rejection, of course, that we have to keep in mind when we are going to replace the endothelium with the donor endothelium. But unlike in PK, the EK endothelial rejection is very, very minimal. And if that is going to give the patient a benefit of so many benefits, we have to consider this, and we can manage them as soon as possible. Yes?
Yeah, go ahead.
Yeah.
Yeah, go ahead.
And in conclusion, like one is more appealing logistical reason, and of course, I'll based on all this this decision mainly on the basic pathology of the endothelial problem, and also the patient's lifestyle, and what I am going to expect in the immediate post-op period, and also the visual symptom of the patient. And if I can give such a clear cornea in few weeks time post-operatively, I would go for it rather than going for edematous cornea like this. Sometimes it can happen, and I can avoid such an embarrassing situation both for me and a painful situation for the patient. Thank you, and stay safe.
Thank you very much, Dr. J.K. Reddy and Dr. Realty. I'm not going to take the questions because we still have 2 teams to go. I would rather have them opportunity to talk and take the questions together. So Harshul, can you introduce the next team? Please stay with us.
Yes, ma'am. So the next topic is very interesting, that you can afford only one equipment. So what will you purchase? Either a high-end phaco machine or invest in an optical biometer. So to debate that, we have two of the great surgeons from Rajasthan, and Dr. Mukesh Sharma, who wants to upgrade to high-end phaco machine. He is heading the Center for Sight, Jaipur branch, and he's a true all-rounder who does cataract, refractive, cornea, and oculoplasty with equal expertise. And his opponent is none other than Professor Pankaj Sharma. I take proud privilege to introduce him, as he has been my guru from my postgraduate days way back in '99. He is a great teacher, a prolific surgeon, great academician. He's a senior professor in SMS Medical College, Jaipur. He's liked and respected by all his students for years. So first, let's hear from Dr. Mukesh Sharma that why does he want to purchase high-end phaco machine. Dr. Mukesh, sir, are you there?
Yes, Dr. Mukesh is there. Dr. Mukesh, can you unmute yourself?
Just a sec. Yeah. Am
Yeah.
I audible now?
Yeah,
Yes, yes, sir.
Be louder.
So at the outset, I'm thankful to Dr. Chitra, Dr. Harshul, and team ARC for having me here. The topic is that I can only upgrade to one instrument, so I'll go for high-end phaco machine. So now I feel, where is the debate? Just to have a debate now in this straightforward answer, Dr. Chitra is very smart and she has pitched in Dr. Pankaj Sharma against me. Dr. Pankaj was my senior in SMS Medical College, Jaipur, in my undergraduate days. Then he was senior to me in RP Center. Then he was again senior to me in SMS Medical College as faculty. So he is my super boss. And there is a dictum here, boss can never be wrong. Now, after 5 minutes or so, Dr. Pankaj will say, Mukesh, it is sunrise time. And I'll have to concede, yes, sir. Maybe sun has just risen 11 hours back. So anyway, so with this, I start my presentation. It's not moving forward. Yeah. So we all know that phaco machine is the lifeline of all ophthalmologists, all comprehensive ophthalmologists, I should say. It is bread and butter for us. 60 to 90% of the earning of an average ophthalmologist is done by phaco machine, and 90% of the OT time is spent is done on this tool. So that's why there is no secret that first instrument which needs upgradation is the phaco machine, because it increases safety to every single patient you operate upon, and also it gives efficiency and comfort to you every time when you enters in the OT. There are various advantages of a high-end machine. We all know about them. There may be various modes like micropulse mode. Fluidics is better. There is better anterior chamber stability. Tubings are disposable. No fluid entering in the machine. Better sterility. Better holding ability at lower vacuum. Better followability. Optimal vitrectomy setting. This is very important. If you have PCR and if you are having a good machine, then you may have a machine with cut rate of 2000, 3000, and you can do a very good job. Then there may be option of fusion fluidics with a dual pump. You can use Venturi or peristaltic pump for same or for all of the case. You will be having advantage of dual linear foot pedal, and also you may have advantage of bidirectional phaco, either with ozil or with the ellipse handpiece. So there are various advantages of a high-end machine. I need not to go into those details. As I told you, a high-end machine increases safety in all patients. It gives you more predictable outcome, and it gives you a peace of mind every time. It is efficiency and comfort. A baseline machine may be effective, wherein your input and output may be the same at the most. But if you are having a high-end machine, then your efficiency will definitely be more, and your output would be several times more of your input. So this is where a high-end machine scores over the baseline machine. A very simple example, if you want to move some articles in a square container, you will have to put more force and you will not be able to travel a long distance. But if you place those articles in a rounded container, then you will be able to travel a long distance by applying a lesser force. So this is a very simple logic. Efficiency, if you increase efficiency, your speed increases, your quality increases, and thereby effectively cost decreases. If you want to travel in a car, obviously you would choose a car where all the safety measures are there, like seat belt, like ABS, like all airbags. You do not like to travel in a car where these features are not there. And in a case of car crash, you obviously want to be in this particular situation where you are saved with minor injuries. But if your car is not having good safety measures, then you can have serious injury, and you do not want to see yourself, and also you do not want to see your patient to land up in such conditions in a case of complication during your surgery. So a high-end machine can handle complications better, like PCR, definitely, than the baseline machines. So when you purchase a car, you look for all safety mechanisms, comfort and efficiency, like tiltable steering, good cabin comfort, automatic transmission, etc. Similarly, for a good phaco machine, you want to look for all these features, and you want to upgrade at the first given chance.
1 minute.
Whenever you are operating on a basic machine, you are definitely under stress. You can see frown line on the forehead if person is operating on a baseline machine. But if you are operating on a high-end machine, you are really relaxed. This is Ellipse handpiece, good machine, and you are not having any stress at all. If you are operating on a difficult case like a microcornea with ciliary coloboma, hard cataract, in a base machine will have problems because AC is really shallow, and this patient is one-eyed, other eye was having severe microphthalmos. But with high-end phaco, your chamber will be always stable, rock hard, and there will be very good followability. You just keep your phaco needle in the center of anterior chamber and everything will come into it. So this is the advantage of a good high-end machine, and it will give you more peace of mind, and it will give your patient better safety and security. So to conclude, high-end phaco machine imparts safety in every case, every single case. It increases efficiency and improves result every time you enter into your OT, and it reduces stress and it gives you peace of mind every time. While optical biometer, it is a useful tool, but it is down the preference, not the first preference tool. Most good A scans give optimal results in more than 99% of the cases. For rest, less than 1% case, you can always take help from your colleague. You are all, anyway, you are referring your retina patient to your retina colleague. Similarly, you can send patient with, say, LASIK, previous history of LASIK, and also with very long eye and very short eye to your fellow colleague who are having optical biometer. Thank you. Thank you for your patience here.
Thanks, Dr. Mukesh. That was nice. So, Dr. Pankaj, could you share your screen?
Yes, yes, Dr. Mukesh, can you stop? Yes, okay. So, excellent talk by Dr. Mukesh. I thank Dr. Chitra for having me here. And wait, where is my screen gone?
What is just stop share and start again?
Okay, I'll stop sharing again. Yeah, I'll start again. That's right. So I would like to clear the confusion which has been created by my previous speaker, because there was so much of talk about so many cars, but we had little talk about phaco machine. So I can afford upgrade of only one instrument. I have no financial disclosures. Well, I tell you I could afford only one. So just to make the things very clear, I have taken the liberty of indulging a bit of theatrics. I would recommend you to put on your earpods and headphones. So you have just bought a new phaco machine costing 60 lakhs and you are entering the OT bubbling with confidence. Oh, look, so many controls. Oh my goodness. I can bake this cataract within 2 seconds. but it's you who is having the hypertension while operating. And the machine manufacturers are having a mojito in some 5-star hotel. So great work done, and you are congratulated by all your colleagues. And great job done. Basking in the glory. Come the first post-op day. What just happened there? So just divine. What went wrong? It's biometry. Improperly done or a challenging biometry can undermine the outcome of surgery of even the most skillful surgeons with the most expensive operating instruments, equipments. So what are the facts? This is a study of causes of cataract surgery malpractice claims in England in a 13-year period. You'll be surprised to see biometry related paid and closed claims, not just malpractice claim, but which were paid and closed were next to only anesthesia related complications. Hundreds of thousands of pounds were paid and closed, and because of wrong biometry. You can see that only second to anesthesia related complication. Now, I won't go into the details as to what an ideal biometer should be. Well, one thing which every one of us doesn't look into is this. Every biometer should have minimal operator bias. The technique should be simple. There should be minimal manual entries. You have talk of so many online calculators where you have to feed in everything. But you just see this. This is AIOS Master 700 and LensStar. It has valuation checks of all in all optical biometers. They are initially valuation checks. If there is something out of the line, it will advise the optometrist or your resident that the MD needs to confirm it. An optical biometry represents a 5-fold increase in the accuracy of axial length measurements, and axial length is the most important determinant of accurate IOL power. So here we have the AIOS Master 700. It has got telecentric keratometry, total keratometry, posterior astigmatism, all the formulae, central topography. It has fewer refractive surprises. It detects unusual geometries, detects poor fixation, cataract penetration very high. It can even do a macular OCT. You can see here the printout is so thorough, and you can have the actual alignment of the toric IOL right there. So you won't have to manually enter K1 and K2. God forbid if K1 is entered as K2 and K2 as K1, you'll have a transposed toric IOL. So here everything is done automatically. There is less chances of human error. Now coming to the science. Now torsional and longitudinal ultrasound mode on phacoemulsification. This is 10-year data. No doubt the CDE ECL was minimized, but there was no difference in the uncorrected and best corrected visual acuity. Now, talking of active fluidics, there are few studies. The CDE is reduced. The endothelial cell count has not yet been studied. Again, there is no difference in the uncorrected and best corrected visual acuity. What about the femtosecond? 2 large trials, one in America and one in Europe, have been recently concluded. They were the non-inferiority trials. Both had the same answer. Vision, patient-reported health, safety outcomes, same. Flax is not cost-effective. Both the studies show this. So what is flax? It is a very, very expensive cystitome, what I feel. So combining the logistics with science, a non-longitudinal phaco is better, no doubt. But micropulse, burst, or even the compact machine of AMO, it is good enough. With a good surgical skill, you can get away with excellent results. Optical biometer would cost you somewhere around 25 to 35 lakhs, whereas a high-end phaco, upwards of 60 lakhs. Femtolaser, well, I always say femtolaser cataract system is the ultimate solution to a problem which we never had in the first place. So this is the last slide. Last slide. So you have a standalone practice. You are doing 50 to 100 IOLs. You're getting good results. You're getting occasional biometric surprises because you're not going to do all the biometries yourself. Your residents, your optometrists are doing the biometries for you. You invest in a high-end phaco. You spend 60 lakhs. You increase your EMIs. You increase your cost of disposables. You become more aggressive in your cataract surgery. You start pushing patients for premium IOs, but you're stuck with the same ultrasound and manual K biometry. Too many manual inputs, too many operator error points. You still keep having occasional biometric surprises. You invest in an optical biometer. You have state of the biometry at your fingertips. There's minimal operator error. Instead of putting in money on EMI and disposables, you should invest in good OVDs that will give you much more good results. Have the basic non-longitudinal and micropulse platform is good enough. Remember, the surgeon drives the machine and not vice versa. And ultimately, you'll have peace of mind. So that brings to into my talk. Thank you very much. It's open for discussion now.
That both of you debated very well, and each of you gave great interesting thoughts about why you should do what you do. If we have time after our last speakers, I will come back to all of you. So our last team is to be led by Dr. Vivek Varkar and versus Dr. Kavita Kalaivani. Dr. Vivek is a consultant pediatric neuro and strabismus surgeon at Miriam Hyman Children's Eye Care at LV Prasad, Bhubaneswar. He has had many contributions in papers and publications and is going to be talking on why he would combine cataract and strabismus surgeries. Dr. Kavita Kalaivani is a consultant pediatric ophthalmologist from Shakar Netralaya, Chennai, another prominent figure with a huge contribution in papers and publications, and she would debate as to why these two have to be separate events. On to you, Dr. Vivek.
Yeah, thank you very much. Am I audible, Dr. Chitra?
Yes, yes.
Yeah, thank you very much for this, opportunity. So basically, my talk today is, the two birds in one hit. So the combined surgery for strabismus and cataract. So I do not have any financial disclosure for, the slides which I am going to show. But yes, I do have a disclaimer. All contents in this presentation, even those based on a true and a proven information, are not meant to cause any grief, harm, or discomfort to any one of the groups. It is used and presented in a coarse and a humorous way on the name of creative freedom. So basically, it is believed by and large, and my opponent, Dr. Kavita, that, the stage approach of the cataract followed by the strabismus is best, but I would prefer to combine surgeries to tackle both strabismus as well as cataract in one go, because they are as uncomplicated and safe as the stage approach. Rather, limited exposure to the anesthesia for children required for stage surgery. And as a strabismus surgeon, we have been taught by Dr. Von Nuden that the procedure of choice must be decided upon on an individual basis. However, some favor one over the other, definitely with the evidence around. So I was reviewing the literature, to work on to this topic, and we are aware that such a combined surgery has been performed for last 35 years in our community. So if you look at the evidence, yes, there is evidence. There is a very interesting paper that is published in JCRS by Dr. Malzman, who has shown that this approach is uncomplicated and has good outcomes. The one surgical procedure is not detrimental to other. Even the very interesting study by Dr. Tico et al., who has shown that there are no reports of excessive postoperative discomfort. Overall success rate is around 67 to 75%, and the strabismus surgery success did not correlate with the visual acuity recovery. So having said that, one can understand the significant amblyogenic structural abnormalities, adult with long-standing dense amblyopia, and absent binocularity since childhood, that would all lead to a poor binocular potential. But if you look at, what Dr. Kushner has to say, that this assumption may not always be valid, and also reported that, the post-operative diplopia is very rare. So if one would read these amazing papers by Dr. Kushner, in addition to that, there are other studies who has, done the combined approach and shown that there is a demonstrable fusion post-operatively. So combining the surgery, again, there are people who has talked about not only, the routine strabismus surgery, but they have tried to do a adjustable suture and proven that this could be one of the alternative. It's a less time consuming, faster cosmetic and functional rehabilitation in one go. So with these two important papers, there is a very interesting letter to editor where, both authors like, the Basmak and Tico, they talk about, they have achieved excellent results in terms of strabismus alignment post-operatively and attributed this high success rate, by performing the adjustable suture. At the same time, Dr. Tico said, our study demonstrated that reducing the surgical amounts in this setting often led to undercorrection. So while standard surgery generally yielded excellent results, even with or without adjustment of the sutures. So then I thought, okay, what about, the Indian context? And, thank God I could find a paper from Shankar Netralaya, Dr. Sujata Guha and, the T. Sundaran group. They have published and shown that, in 15 retrospective patients, their success rate was, quite comparable. And they concluded that, the combined approach is effective, safe, and cost-saving procedure in a selected individuals. So then I thought, okay, let's do. Dr. Chitra asked me, okay, can you, flip the topic and can you do this? So I tried myself, performing this combined approach. So why I'm showing this surgery? Because it's very important, which I decided to do some modification, like fornix base, the conjunctival suture, and not usual limbal base if you are planning to do, the combined surgery. And most of the time when you plan, touching the muscles, I prefer to irrigate with, the betadine as and when required, or I would say, more often as a part of safety for the infection or a risk of, the endophthalmitis. So I think there is no difficulty, and here I chose, the kind of a moderate strabismus and selected doing resection surgery, because in literature it has shown that, there is a post-operative discomfort, but I wouldn't see any post-operative discomfort when I chose to do a resection as a combined approach. And after that, again, at the end of surgery, the frequent copious use of betadine is the way forward. Then the same patient, I did keratometry on table. It's a pediatric cataract actually. So again, here, the most important step is, the closing the side port towards the incision site is very important. You have to be very precise and make sure that, there is no bleeding, no hematoma, and then you can complete the surgery. So at the end of day, my choice is always to hit, the two birds by one hit. And I could conclude that it is a safe and effective way of doing it, and definitely an alternative useful option in selected cases, like, the strabismus along with secondary IOL, strabismus that develop cataract in adult life, and those with dense amblyopic eyes that were not treated for childhood cataract at the right time, and, the decompensated intermittent XTs due to the cataract. And it can be a definitive option in developing world like ours, where the cost constraint and infrastructure is limited. So the debates that I said, it could be a creative freedom, and that had given me a new avenue of asking the research question. So can we look at the RCT, combined versus stage approach and dosing of the strabismus surgery? Because there is a gray zone in the literature, can we do a standard versus, the underdosing as far as the strabismus is concerned? Thank you very much.
Thank you very much, Dr. Vivek. That was a very interesting presentation. Definitely you will have questions after Kavita has done her bit also. On to you, Dr. Kavita.
Thank Dr. Chitra ma'am, and actually I thank Dr. Vivek also. He has made my part a little easier, especially with this last slide. Actually, the last slide, he has proven that he has given me an idea actually that he already is he's coming to my side actually, saying there is a debate, right? So cataract, when squint and cataract coexist, whether to combine or not, that's what we are talking about now. So do they coexist? Of course, they do coexist, especially when there is an untreated childhood strabismus with age-related cataract, like infantile esotropia or exotropia. You can have squint and strabismus together. A long-standing acquired strabismus with recent onset adult cataract, like nerve palsies, thyroid-related strabismus, they can coexist. Post-trauma sensory strabismus with cataract, post-surgeries like scleral buckle, glaucoma implant surgeries, and sensory strabismus. So these are various situations where strabismus and cataract coexist. And pediatric, as Dr. Vivek said, it's very common that they coexist because many times you have unilateral cataracts, asymmetric bilateral cataracts, steroid-induced cataracts, uveitic cataracts, where a strabismus can exist along with cataract. So indications to combine both. He was trying to justify that we combine both. So you combine both because I know to do both. Yeah, I and Dr. Vivek happen to be strabismologist as well as cataract surgeon. So we do combine because we know how to do both. It's because patient wants both. No time for the patient. Many times we come and the patient is in a hurry that next month I have a marriage. So please do both for me, doctor. So are these the indications or are there actual indications? There definitely are actual indications when we do combine both, when we can combine both rather. So like I said, childhood strabismus, when both are independent problems and they coexist, yes, you can manage them together or separately. There is really no big difference. And very rarely there is a situation in cataract surgery where there is a very long-standing restrictive strabismus. Sometimes the cataract surgery is difficult to perform without first tackling the strabismus. In these situations, yes, these are indications where sometimes we combine these two procedures. Both are independent problems. Like I said, infantile ET with age-related cataract. Yes, these are situations where we can offer a combined therapy and patient is happy. To facilitate cataract surgery, like I said, there can be situations like this, bilateral 6-nerve palsy with extreme adducted eye, that to do a cataract surgery like this situation, you need to actually bring the eye to a little more comfortable position for you to perform a cataract surgery. But when not to combine, this is where we have to be really, really careful. A double vision. So Dr. Vivek, I don't know by this, or he happily tried to not talk about this major problem where strabismologists come in picture. So this is a case of a thyroid of orbitopathy patient, squinting with occasional diplopia, stable angle since 6 years, a left convergent squint with restricted adduction elevation in both eyes, and 55 prisms esotropia with cataract in both eyes. So here, what do we do? So I would rather do a cataract surgery in each eye, reassess the diplopia, squint surgery if fusion and only if fusion is present. So this is not a situation where I would jump and combine and do the cataract surgery just because it's convenient. And when strabismus is recent, but cataract is before strabismus onset, like decompensated IDS due to cataract. So this is a very common situation. Sometimes patients with occasional squinting on and off become a constant squint because of an onset of cataract, like this gentleman here. So he has no other problem. So now what? Again, I would rather do each eye cataract surgery, reassess the squint. The squint surgery the cataract surgery may itself improve the control back to his original condition. And if not, then if angles are stable, then we do a squint correction. And sometimes the squint and strabismus, the strabismus can be long, but not long enough. Like for example, a patient with a trauma of 10 years of age with a traumatic cataract ignored and now comes with a sensory exotropia. Here is a red flag. Here there is a situation called central fusion disruption, which the same article he had quoted, Dr. Kushner warns about this. Diplopia may be very as less as 0.3%, but when it is there for the person, it is 100%. So here, this is a situation where we never combine a squint surgery along with a cataract surgery. And pediatric, I would never combine them. Ideally, why not? Because vision improvement always comes first, as we are taught that amblyopia can improve the alignment. And after you do a both combined surgery, if the patient still remains amblyopic, the parents get discouraged to do amblyopia therapy because you're aligned. And recurrences in this situation is very common with respect to the squint, and consecutive strabismus is very common if the vision is poor. So the red flags when we see cataract and strabismus together is pediatric, sensory strabismus where unpredictable vision potential is there, and diplopia. So as always in medical practice, it is as important to know what not to do. So thank you so much for your patient hearing.
Nice talks, both of you, in spite of the fact that somebody has to become the last team, and I was feeling so bad about it that it went on and on. And I even curtailed the discussions, but the talks were good. So I have one question for both of you. You all could answer this. Is there any sense, if at all, even Dr. Vivek, I think, doesn't do combined surgery largely. He took it up for the sake of the debate. But is there any issue with doing a combined surgery with the toric IOL?
Dr. Vivek, you want to answer?
You want to answer this?
Yeah, I don't do the toric IOLs. I don't do adult cataracts. Yeah.
We would rather probably defer it and either do the cataract surgery, because there is a small evidence to prove that strabismus surgery can alter the astigmatism to a slight extent. So we would not combine that situation.
And what are your thoughts on combining Botox injection to the muscles along with doing a cataract surgery? Like supposing the patient has some nerve.
Probably a similar indication, ma'am. I have no experience, and there are very limited studies also. Surgeries, yes. I also have done actually several surgeries in adults who have had squint and cataract, where both are literally independent procedures. But Botox, I do not have an experience or.
Yeah, I think the combining the cataract with strabismus and that too with the Botox, I think there is no literature on this. Okay. So other than cataract, like, infantile ET, there is a lot of things going on, like doing bilateral MR with or without Botox, or, the Botox along with as an additional, the less recession, and then you top up with the Botox. So I think despite all this, the overall success rate of using Botox alone versus, the standard strabismus surgery, the success rate is not more than 50%. So I think at this time point, I think the bilateral recession with or without, the cataract would be the standard of care.
Just one simple, thanks a lot. Just one simple question. The DSEC FACO is Dr. J.K. Reddy and Revati are there. We just as a comprehensive
yes.
we wanted to know what would be a surgical incision when you do a combined surgery. Would you do a sclerocorneal or an incision beyond the graft? How would you do
I do corneal only. I do corneal.
Corneal only. And
yeah,
what?
Corneal only.
I do just like a FACO, but we just enlarge it to 4.5 mm. Then insert the if I do DSEC, most of the times we are not doing DSEC. DSEC is almost, unless there is no iris, something like that. Most of the times we do DMEC, so you don't need to enlarge. If I do DSEC for any other like atrophic iris or some other problem, no iris, something like that, very rarely we do. So I enlarge it to 4.5, then insert the DSEC graft.
How would you IUL part modification? How would you modify it when you're doing a combined procedure?
Revati?
Yeah, see, if it is DSEC, there is a theoretical, like there may be a hypermetropic shift. So accordingly, we may have to adjust. But if it is a DMEC, there is no need at all. Like you can just go.
Even DMEC, madam, what we found is for the cases which comes to us for DMEC, not very clear epithelium like what we are seeing in US or in the Netherlands series. Our epithelium, most of the time there will be edema and bulle. So you don't get a K reading. So we just sent for a scan. They take some readings and measurement. They're not good. We have to take a topography, especially the placido based is very good. We look at the placido Myers itself. If the Myers are irregular, then you have to just estimate power. You cannot take K reading serious, even in DMEC.
Yeah, that's what you should do when the cornea is clear.
Not even pentacam. Pentacam is useless. Pentacam gives some readings and it's good for nothing in these cases where there is a corneal irregularity. The placido one with the placido Myers we have to see, not the analyzed results.
You missed the dig that Revati hit at you. She said you should do a combined when the cornea is still clear. So anyway, this is not, normally we do have all our expert panel right till then, but today there have been some webinars going on simultaneously, so we've lost some of them. So anyway, a webinar on debate series, I'm sure as we also saw, thrashes out a lot of controversies and we ourselves get to think in a different angle about it. A very special thanks to our very elite expert panel, our popular speakers for making this webinar truly interesting. My thanks are due always to my very capable ARC team and Harshul, who has been so active and involved in this particular section. Our thanks are due to Mr. Kripal and his able admin team at AIOS. Mr. Sunil, whom you must all know is a webinar administrator, and he contributes really significantly to a smooth running of the webinar. Mr. Sai and Manjula from Numerotech, who have been our essential support. And of course, our constant support have been entered as they have sponsored every single ARC program. And finally, and always, we owe our thanks to all our attendees for encouraging us to give our best for these webinars. And thank you so much, one and all of you. You all was absolutely top class, terrific speakers. Thank you all. Thank you very much.
Thank you.
Thank you.